Hello, my name is Justina Maid, and I would like to welcome you to our sixth annual Bronchiectasis Patient Conference. Before I tell you a bit more about myself, I want to tell you about the translation app that we are using today. It's called Wordly, and it provides automated translation in over 60 languages. We have posted the link in the chat box, or you can scan the QR code on the screen. When you access the app, first of all, select the language you want from the drop-down list and then click Attend. Wordly will open in a screen and you can position it alongside the webinar to view both screens. You can read the transcript on your device or use a headset to listen to the audio. We know that automated translation is never perfect, and some of the words and phrases may not be quite right. But we hope that it will help make this conference more accessible for many. If you have any problems accessing the app, please email info@europeanlung.org and a member of ELF team will help you. Now I'm going to tell you about myself. I'm Justina Maid, I'm French, and I'm a patient living with bronchiectasis and NTM pulmonary disease. NTM means non-tuberculous mycobacteria. I'm member of the Bronchiectasis Patient Advocacy Group since 2024. I hope that this conference will provide me with relevant advices and information to better understand my pulmonary condition. And now I hand over to my co-host, Professor Stefano Aliberti, to introduce himself.
Thank you, Justine. Good morning, good afternoon, everyone. My name is Stefano Liberti. I'm a professor of respiratory medicine at Humanitas University in Milan, and I'm the chair of the Department of Pulmonary Medicine in Humanitas Hospital in Milan. I've been working with the European Lung Foundation since many years, and I strongly believe in this kind of event because this is the opportunity for us as healthcare professional to explain a little bit more about the disease and have patients asking questions in order to clear some issues that might be in the mind of people with bronchiectasis since many years. There are plenty of experts and patients connected today, and I strongly believe this will be a great event at worldwide level. I have some housekeeping to make you aware of. First, webinar attendees can only see speakers and chairs and the host, so we cannot see other participants. Everyone is on mute, so we can't hear you, but you can participate in the chat and through the Q&A question and answer, and we strongly invite you to do so. Concerning the question and answers, please write your questions for the speakers in the Q&A board. Then we will try to answer as many as we can in the time we have. Those not answered, we will try to get answers from the speakers after the event and put these on the ELF website after the event. There are expert clinicians answering your question today. Please keep in mind that we cannot answer questions about anyone's personal circumstances or cases. Something about the pooling. There will be some pools that we will ask you to participate in through the day. So please take part if you can. In terms of social media, if you are using or use social media, then please tweet using the hashtag Bronchiectasis 2026 and tag ELF, European Lung Foundation, Embark, and the ERS, the European Respiratory Society, using the X handles shown on the slides. The conference is being recorded and talks will be made available on the European Lung Foundation website and the European Respiratory Society channel after the event, so you and others can freely access them. We will send on the links in an email to all the attendees. Usually it takes about 2 weeks to get the recordings on the website. Now, today's conference is organized as a collaboration between the European Lung Foundation and its Bronchiectasis Patient Advisory Group and the Embark. You can find out more at the links shown on the slide. We especially thank all the members of the European Lung Foundation PAG, Bronchiectasis Patient Advisory Group, co-organizers of these events who help a lot to make sure the talks today are important and relevant to people with bronchiectasis and their family members. One special thanks go to Justine, Eliza, and Jennifer, who were part of this year's planning group. Thank you also from my side. It's a pleasure to work with all of you. And now I would like to handle back to Justine. Thank you, Justine.
Thanks, Stefano. So today our audience is made up of people with bronchiectasis and their family members, but we also welcome healthcare professionals, medical students, patient organization representatives, and members of the public who have joined us to find out more about bronchiectasis. We have had over 1,400 registrations for this event. Wow, so many. Remember to put your questions for the speakers in the Q&A box, not in the chat, please. And please write any questions in the Q&A that you most want answered by using the thumb up icon. This will flag them up for attention and help to avoid duplication of questions. And now just a bit about the outline of the day. We have a mix of patient speakers and healthcare professional experts in the field of bronchiectasis and other respiratory conditions. You can access the program by clicking on the resources icon along the bottom of the Zoom screen. It's also available on the ELF website, and we'll put the link into the chat. There are 4 sessions today, and each has 2 co-chairs, a patient and a clinician. There's time allocated for questions after each question. As you can see on the screen, we have a first session, bronchiectasis basics, then a little break for a coffee, then session 2, all about infections, followed by a little break. Then session 3 will talk about how to live well with bronchiectasis, then a little break, and finally, session 4 will talk about advances in bronchiectasis. Now I leave the floor to my co-host Stefano.
Thank you again, Justine. Now, before we start the first session, we would like to run a poll asking you the rate to rate your level of knowledge about bronchiectasis. Uh, Rate from 1 to 10, where 1 is no knowledge, up to 10, which is extremely knowledgeable. Now, Claire, would you please put up the poll for us?
Can you see the results,
Yes.
Stefano?
Yes, I can see the results. So I think there is a very nice distribution in a sort of Gaussian type of curve. So we have the majority of the people rating in between 5 and 7 and 8. But we also have people rating 9 or 10 or 1 to 3. So it's we are expecting to have a very mixed population of people listening the conference today, with the majority having a 5 out of 10 knowledge in bronchiectasis. So I really hope the discussion today will improve this knowledge also through a couple of questions you might have. Please use the question and answer box to ask the question and not put the question on the chat. And now we would like to introduce our first session. The first session is bronchiectasis basics, and it's my pleasure to introduce Dr. Arietta Spino to give us the first lecture. Dr. Spino is a lecturer in cardiorespiratory physiotherapy practice and research at King's College in London, in the UK. She's a specialist respiratory physiotherapist, and she has extensive research experience with a special interest in bronchiectasis. It's part of the ELF and the Embark community, and it's a pleasure for us to have Dr. Arietta Spino to deliver this first lecture. Thank you, Arietta.
Thank you very much, everyone, and thank you for the invite. I think it's a real privilege to open this conference and be with you for another year. I have the very difficult task of actually presenting an overview of the bronchiectasis, and I think if you can share my slides, that would be great, because I have some issues with sharing.
Okay, bear with me. I'll just get them up.
Thank you. So in my presentation, I'm going to go through the basics of bronchiectasis. So it's going to be really an overview for everyone. If you're new to the bronchiectasis diagnosis, and if you're knowing a little bit more, and I'll focus on patient-managed interventions and a little bit on airway clearance techniques, which is my special interest. Next, please. So I don't have any conflict of interest. Next, please. So bronchiectasis, as you might probably know since you're here, is a chronic lung disease. It's characterized by airway abnormal and permanent dilation. And I'm going to show you a few pictures about how this presents in the lungs later on. But you can see the CT scan where we see a picture similar to a ring. So you have the characteristic dilatation of the dilatation of the airways, with the signet ring sign. And the symptoms of bronchiectasis is that people have more phlegm than usually, so they have impaired mucociliary clearance. And again, I'm going to show you what this means in a later slide. They have cough and secretions of sputum they bring up, and they can experience breathlessness or dyspnea, fatigue. So they're getting tired more easily, and this can be physical, but also mentally. Sometimes they present a little bit of phlegm, or in their phlegm, a little bit of blood, which is called hemoptysis, and they can have frequent respiratory infections. So they can get unwell and have more of their symptoms that indicate an exacerbation. Plus, they can also present a reduced exercise capacity, which means that they cannot do as much as they would normally without the condition. Next, please. So the very important thing to remember about bronchiectasis is that it's quite variable. So there's lots of differences between individuals who have the same diagnosis. So bronchiectasis can present have different manifestations. It's a heterogeneous disease, so there's different presentations in people. And also within the same individuals, these symptoms can fluctuate. So they can change depending on the condition, depending on the day. And sometimes the burden and the consequences we have in the daily life can be underestimated. So it's important to understand that everyone is different, and you think about your symptoms and what is normal for you. And most of the people, of course, report that they present this daily cough or phlegm, and they feel tired or they have exacerbations of the condition. Next, please. So I'm going to go through very briefly the anatomy of the respiratory system because it's important for us to understand what's the issue. So it's a structural damage in the airways. So you can see the airways that are normally developing into this branch-like tree. So that's the bronchial tree. And they become gradually thinner and thinner. So they start from the trachea, which is quite large, and then the bronchi, and then they become into smaller branches. And then we have the gas exchange in the alveoli. Next, please. In the bronchiectasis, what happens is that this normal reduction of the airway lumen, so how large the airways are in terms of the branch, is disturbed. So in a place, they're actually, you can see the normal bronchus and the bronchiectasis here. So it's not as tight as you would expect it. It's not as well formulated, and it's dilated in a specific area, which has an impact on how these airways can be cleared and what happens there structurally. Next, please. And another important thing to remember about bronchiectasis and the variability we have around this condition is the etiologies, because bronchiectasis can be caused from many different causes. So we have cystic fibrosis, which we usually assess as a separate thing. We have bronchiectasis following an infection, so something like a severe pneumonia or something like that can cause bronchiectasis. Sorry, if you go back, please. And we have idiopathic bronchiectasis if we cannot identify a specific cause. And then we have other causes such as immunodeficiency, rheumatic conditions, and other. Next, please. So in the airway clearance, we have two main ways to clear our lungs from secretions, from the phlegm. And when we are healthy, this can happen in balance between the ciliary escalator, which are the tiny hair you see on this slide that constantly move and they remove the secretions, and the cough that we all experience if we are unwell and we have some infection. So next, please. Next, you can see how this works, and it removes the tiny hair move constantly in a coordinated manner, and they remove the phlegm. And then if this is not adequate to clear the chest, then we have the cough, where we have this deep inspiration, the glottic closure, and then a forceful expiration. Thank you. Next, please. So in bronchiectasis, we have the pathophysiology model where initially we thought this is actually a vicious cycle. So when you have an infection, this leads to an inflammation. This leads to impaired mucociliary clearance, so we cannot clear the phlegm as easily. And this contributes to the structural airway damage that I showed you earlier. And now we are considering this more as a interrelated model where each component of this cycle has an effect to other parts of it. Next, please. And how do we measure the disease? We have, of course, the bronchiectasis severity index about how severe the condition is, but we also have some simple measurements such as the lung function, where most of you probably have had this blowing test, the imaging, such as the CT scan I showed you earlier, the macrobiology, which is about identifying if there is any bacteria in any mycobacteria in our phlegm, and then exacerbation frequency. And also the treatment burden is one of the things we are assessing when we are considering if someone has improved with treatment. And I have a couple of graphs here, but they are more research related. But what they demonstrate is actually that these outcomes that are lung function or imaging, they don't correlate very well with the quality of life of people. So what the symptoms show us, what you tell as a patient is also very, very important about your condition. And we shouldn't rely only on some objective markers. Next, please. And this graph is from the European Respiratory Society clinical guidelines from bronchiectasis, which were published recently. And it has an overview of the cycle alongside the treatment options. So you can see that for the inflammation, there's long-term macrolides that people might be prescribed. For the infection is long-term inhaled antibiotics for those who have Pseudomonas aeruginosa, or long-term inhaled antibiotics for those who don't have it, or other ways to eradicate colonization of specific mycobacteria. And also when you present with impaired mucociliary clearance, so you don't clear your lungs as well, we have mucoactive drugs and airway clearance techniques, which I'm going to focus on in this presentation. And for the lung damage and managing its symptoms, we have pulmonary rehabilitation. Next, please. So I'm going to focus on the patient-managed interventions. I know we have some doctors talking later on about treatments. So what I mean by patient-managed interventions are those treatments where the patient is actually managing the condition. So they are actively engaged and they also incorporate some behavioral changes. So you might often find them as non-pharmacological interventions. And these are airway clearance techniques, exercise, which is one component of pulmonary rehabilitation, but also self-management plans, exacerbation plans, and maybe some digital health tools. And the idea is that we will empower the patient to be in the center of care. And we are trying to actually improve outcomes such as exacerbation rate, quality of life of people, adherence to treatment, and confidence with how they manage their condition. Next, please. So airway clearance techniques is a key component in managing bronchiectasis. And those are techniques and devices that have been employed alone or in combination to facilitate the airway clearance and render cough more effective. So the aim is to try to remove the secretion and phlegm from the lungs. So we actually label airway clearance techniques those who have as a primary aim to achieve airway clearance. And this can be techniques such as the active cycle of breathing techniques. So it's a cycle of different ways of breathing, or they can be gravity-assisted positioning, where we use the gravity and take specific position to eliminate secretions. They can be manual techniques that another person applies to the patient chest, and other techniques such as autogenic drainage and alcohol. Next, please. The previous one, please. So airway clearance devices are positive expiratory pressure devices oscillatory positive expiratory pressure devices and the chest vest. And all of these, they actually illustrate that you have a great variety of techniques to choose from. And it is important that we individualize the airway clearance to a specific person according to their condition, their everyday life, and their needs. Next, please. And what we've seen is actually if we take all the airway clearance advice, all the advice in terms of the guidelines and statements nationally and internationally, what they say about airway clearance techniques, next please, is that they are better than cough alone or nothing. So if you think that cough is enough to clear your chest, and if you think that spontaneously coughing will be adequate, this is not true, and this is quite consistent as a message we get from the research and from the guidelines internationally. So we really need to focus on airway clearance techniques. Next, please. And a couple of years ago, we published a statement about airway clearance techniques in adults with bronchiectasis. Next, please. Where you can have an overview of the variable techniques you can choose from. And there's also this table where it presents the advantages and disadvantages of each technique. So if you don't have access to someone, maybe you can have a look and see what you think would be most appropriate for you, but also try to access advice from a healthcare professional. Next, please. So we have seen that airway clearance techniques are advised for patients, and this is strong, but how are we doing so far? And the data we have nowadays show that we are halfway there. Next, please. So the large databases we have as registries from the United States of America, but also from the European Bronchiectasis Registry, EMBARC, show that around 52 to 59% of people with bronchiectasis actually use airway clearance techniques. Next, please. And in the EMBARC registry, which had approximately 17,000 participants, where we had a nice distribution of severity of the condition, so this can be applicable to all the types of severity. Next, please. We saw that although 72% of the people report that they bring up phlegm daily, and that could be around 6 milliliters per day, only up to 50% of those were reviewed by a specialist physiotherapist. So you can see a map here where the light orange is the highest percentage of reviewing by a specialist physiotherapist, and the more red the country is, then the lower the percentage. So some countries have up to 10%, and at the best case scenario, only half of the people can access a respiratory physiotherapist for airway clearance. Next, please. And not only that, but what this table shows is that those who are doing regular airway clearance they are those who have more severe condition. So we seem that we get into airway clearance techniques quite late. So we are quite reactive in how we approach this rather than starting the techniques early enough. Next, please. And now I'm going to briefly go into the pulmonary rehabilitation, which is a program for exercise and education. So if your country and your region provides pulmonary rehabilitation programs, this is programs of 6 to 8 weeks where people usually go in a group setting and they do exercise with others who have another lung condition, and they also have education sessions about how to self-manage. Next, please. And we have seen that pulmonary rehabilitation and especially exercise can improve exercise tolerance. So you can do more after you finish a program of pulmonary rehabilitation. You can do things without feeling so much tired, which is very important for those with bronchiectasis. And also you can feel less breathless when you're doing similar tasks with before. And it also improves quality of life. So we have shown that people who have participated have improved their quality of life significantly. But it's important to understand that also to maintain the benefits, we need to maintain some form of exercise. So it's a little bit of a life intervention, and we need to keep that in our mind for being healthy. Next, please. So exercise capacity is something that pulmonary rehabilitation can improve, quality of life as well, and also probably exacerbation rates. And we don't have enough data about health economic outcomes, but it's also, we can see if that's also good for the healthcare system, because if you feel better, you're less unwell, less time off work, and so on. Next, please. Next, please. So getting to the end of my presentation, we have also some innovative ways that we are considering about patient-managed intervention. So in our group, we are investigating with from a grant from Asthma Lung UK if laughter classes for adults with bronchiectasis could actually help them improve their quality of life and management of secretions. So we are currently developing an intervention for that. Next, please. So overall, patient-managed interventions are important, and keeping the patient in the center of care is key. Next, please. So bronchiectasis can be variable, and I'll show you the reasons for that. And patient-managed interventions alongside medical treatment is important. Airway clearance techniques are key to the management, and part of another key component is exercise and pulmonary rehabilitation, which can be beneficial for exercise tolerance and quality of life. So please, if you're a patient or a relative, ask for help and advice from healthcare professionals, because you really need to address this quite early. Next, please. Thank you very much for listening. And I think having this conference actually demonstrates that having the patient voice in the center of research and care is essential. Thank you.
So thanks a lot, Arietta, for this brilliant and complete presentation about for this overview of bronchiectasis. I'm sure you will have a lot of questions afterwards. Thanks a lot, really. So now I want to introduce Janet Boyd and Lucy Robinson. We will talk about the ALF Connect Bronchiectasis online platform. So Janet Boyd works in the European Lung Foundation's Patient Involvement and Engagement team. And Lucy Robinson is the Communications and Information Lead at the European Lung Foundation. So now, Janet, the floor is yours.
Thank you, Justine. I'm just going to get my slides up. Hopefully you can see those. Okay, hello everyone. I'm really happy to be here to tell you about a new online platform called ELF Connect that we will be launching in the next few weeks. This is a new platform to help bring together people living with lung conditions and healthcare professionals, creating a single space for an online community. Trying to move my slide on. So the platform will have distinct areas for different lung conditions. And the first area we are launching is for bronchiectasis. And our goal is to provide a dedicated space for engagement and trustworthy health information. Everything on the platform will be available in different languages to make it accessible, and all the content is from ELF, the European Respiratory Society, ERS, and EMBARC. And there are 3 core features to the platform: an artificial intelligence AI assistant, a powered search area to help people find the resources they are looking for from trusted content. There'll also be a space to submit questions to get a response from a healthcare bronchiectasis expert. And then there'll be a community space where patients and healthcare professionals can connect. So let's look at how these 3 features will work. You can see on screen the Search Our Resources area, and this will use AI to scan only verified content. So this means that you can get accurate, evidence-based answers from ELF, ERS, and EMBARC without the misinformation often found on standard search engines. But if your search doesn't quite cover a specific concern, then the Ask an Expert tool steps in. And if a question has been asked before by somebody, the AI assistant will provide the answer instantly. But if it's a new question or a more complex query, it can be passed to a healthcare professional for a more personalised response. And then the community area will be a space for patients and healthcare professionals to further engage together. So here, medical experts and members of the ELF Bronchiectasis Patient Advisory Group can start discussions, run polls, and host surveys. So it's a place for patients to have their voices heard and for healthcare professionals to stay connected to the lived experience of people with lung conditions. So finally, we're now in the pilot phase of launching ELF Connect, and we'll be looking for new members to sign up in a few weeks' time to explore the site. So we'll get in touch to let you know when you can sign up, and we do hope you will join us in this new online community. And if you have any questions today, please put them in the Q&A and my colleague Lucy and myself can answer them. Thank you.
So thank you, thank you very much, Jeanette. This is a great initiative. Congratulations for the hard work you have done, you and the other colleagues have done for that. Now it's my pleasure to introduce our next speakers, who are Suzanne Mienen and Dr. Mattia Nigro. They will be presenting about the bronchiectasis patient journey. Suzanne was diagnosed with asthma at the age of 24 and with bronchiectasis at the age of 47. She has a background in the biopharmaceutical industry, but now works as a business mentor and a patient advocate across several arenas. She joined the ELF PAG in 2025, and she's very passionate about raising awareness of bronchiectasis and the implications of living with these chronic diseases. Dr. Mattia Nigro is an internal medicine physician and PhD at Humanitas Research Hospital in Italy. He is working at the pulmonary unit in Humanitas and at the bronchiectasis program in Humanitas Research Hospital in Italy. Is part of the Future, which is the early career member group of EMBARC. His main clinical and research interests are in bronchiectasis, acute and chronic respiratory infections, and it's a pleasure for me to give the to handle over Suzanne for sharing her slides. Suzanne, the floor is yours.
Thank you. I was just unmuting. Okay, I should just share my slides. Can you see that in full screen? Yeah. Okay, so this session is about the patient journey and what the ideal patient journey might look like. And so in order to inform that, we decided as a group, the patient advisory group, that we would run a survey of our membership to see what their patient journey had been like previously. Now, recognising that some people were diagnosed a long time ago, I would hope that things may have improved a little, but I still think it's useful to learn from previous experience. So we surveyed the full membership and we received 31 responses. Although a large proportion were from the UK, you can see that we had responses from all over the world, which is great. And not surprisingly, most people's symptoms were consistent with what you would expect from bronchiectasis. So cough, sputum production, yellow-green sputum, some of the more familiar sort of background symptoms from having an infection, like low energy and fever, loss of appetite, breathlessness, and then some of the concurrent symptoms that happen with chronic sinusitis, such as nasal drip and runny nose. So our population was pretty typical, so you would have thought that was fairly straightforward to diagnose. When we looked at the kinds of tests and treatments people received from their primary care physician, so the doctor that they saw in the community, you can see here the scale goes up to 100, but it was really quite inconsistent in terms of the interventions that occurred. So around 64% of people received antibiotics, which you would expect, and just under 50% an X-ray. But that's still quite low considering how obvious the symptoms appear to be. Surprisingly, 25% of people didn't receive anything. They just had watch and wait. Many of our respondents felt that they weren't fully listened to, so just over half. And it took an average of 4 visits to a primary care physician before patients were referred, in about 64% of patients, so 2/3. A quarter of people responding to our survey said that they were never referred. However, most of the diagnosis did occur within a hospital setting, in a secondary setting, mostly in outpatients, but some as inpatients. And only 10% of patients were actually diagnosed by their primary care physician. So there's obviously a discrepancy here between the 24% who weren't referred, but only 10% being diagnosed. And there's a concern that those may be the people that ended up as inpatients. So what happened when people got to their secondary care physicians, those that made it through? Again, a huge variation. So over 70% received an X-ray and others a CT scan. So that's what you would expect. And hopefully that's been fairly consistent. But not everybody had their sputum checked, not everybody had lung function. And consequently, the results seem to be, for many people, a huge delay in diagnosis. So shockingly, this large chunk of the pie chart here were patients who it took more than 10 years to receive a diagnosis. As I say, I would sincerely hope that things have improved, but that's the story for many of our people. Still a significant chunk, 5 to 10 years, and 3 to 5 years here. So if you look at this huge chunk here, that's between 3 and more than 10 years. It's an unacceptable, hugely unacceptable delay. The other kind of quarter of a chart were within 18 months, really. So immediately following diagnosis, this is just diagnosis, but what support were people given? So encouragingly, 81% were educated in some kind of sputum clearance or pulmonary rehabilitation, which is encouraging. But 43% felt that they really did not have enough information, knowledge, training on how to manage their condition. And subsequently, as time went on, the percentage of people who had access to sputum clearance, etc., and sputum tests went up to 86%, with 76% having regular lung function. Very widespread difference in terms of access to specialists, but most people had some kind of access, only 77%. So less than 10% had no access. And over time, people became more confident in how to manage their exacerbations, their condition. But most people felt that they learned that themselves, they gained that knowledge themselves over time through organisations like this. And here are some of the quotes from the people who contributed to the survey. And I draw your attention particularly to the last one, which was in response to the question, what was the most difficult part of your journey? And it was having to live with the disease while battling the medical community instead of being supported by it. So the recommendations that come from our survey are primarily more timely diagnosis is obviously a priority. And from the information we collected in the survey, we felt that that could come from, one, patients being listened to more thoroughly by healthcare professionals, by community-based physicians being more consistent with the tests that they do and making referrals. When we reach specialists, again, more consistency in the tests and investigations that are made. And very importantly, that all physicians provide better guidance and information to patients so that they can manage their own condition. And that's it from me. I'll now hand over to our expert.
I will share my screen, so thank you very much, Suzanne. Here it is. Okay, so I will try to implement your consideration in the results of the survey that you showed us with with a perspective that comes from the other side of the barrier, so the a medical doctor's perspective on patient journey. And basically, I think that when we talk about patient journey, we usually have to consider 4 different aspects. The first one is that living with bronchiectasis is not like a 100-meter run. It's more like a marathon. So there are years of or decades of journey that people have to face in the most suitable manner. So it's usually something very long and something that can be good for patient or sometimes can be frustrating according to how the journey has been conducted. There are some challenges that most of the patients face according to the survey that you showed us, the experience of the patient that we evaluate in the clinic every day. These patients usually report to us that they had to face delays, uncertainties, misdiagnosis, and frustration that do not only affect the respiratory part of their own health, but usually have a multisystemic impact because this disease has several psychological consequences, have an impact on social life, on work capacity, and overall on quality of life. And that so the key message here is that we should think about a perspective shift needed. So just not think about how we treat bronchiectasis, but also how to improve the experience of people that live with bronchiectasis. So this is basically in my idea what a journey looks like. So basically the journey begins with the appearance of some of the symptoms. So some symptoms might just be present in a part of the people life. So usually after this, there's ideally there must be a beginning of a diagnostic process in which different investigation, consultation should be performed. We have learned from the previous presentation from Dr. Spino that a chest CT scan is the diagnostic that we usually, in most patients, that we need to perform in order to have a diagnosis of bronchiectasis. And then afterwards, there's a treatment and management phase in which different treatments might be applied according to the specific characteristics of the people that we are facing in a given moment. For instance, airway clearance, for instance, antibiotics, for instance, treatment like vaccinations or other different treatments that might lower the risk of having a serious impact of the disease on their overall quality of life. And then there's the phase of the personal empowerment. So people who got diagnosis with bronchiectasis after a few years and are in control of the disease might actually be positive, might transmit a positive message to other people and feel good with themselves and actually participate into others' journeys. So these are the current challenges. So the delayed diagnosis is actually something really clear. You have shown that most of the patients are face a delay of 5 to 10 years, and I will show you in a bit the situation in the Italian population in a paper that we published a few years ago. There's the issue of the dismissed symptoms. So some of the symptoms of bronchiectasis might actually be normalized for lots of time. So you probably most of the people in the room have heard something like, it's just a cough, it's just a respiratory infection, it's nothing, it's not a big deal. But actually, this is something that is part of the problem and contributes to diagnostic delay and to a management that is not appropriate. The misdiagnosis is actually a problem sometimes because most of the people might receive a wrong diagnostic label, so they might just say you got COPD, you got asthma, you got pneumonia, or you got other respiratory conditions, and sometimes they just receive inappropriate treatment according to that wrong diagnostic label. And then there's the emotional toll that we have talked and that you, Susanne, have showed in the previous survey results. So this is the Italian situation. So this is actually is a study that we conducted retrospectively. So it's actually representative of how was the situation in Italy over the last 10 to 15 years. And you might see that lots of people go all over this vicious vortex of misdiagnosis, treatment initiation, persistence of symptoms, and then another diagnosis that has been applied until they get to a proper diagnosis of bronchiectasis, referral to a bronchiectasis center, diagnostic correction, and initiation of a proper management of the disease. So in Italy, the results of these studies showed us that the time from symptom onset to a chest CT scan is actually two years and a half, to the clinical diagnosis of bronchiectasis as a disease is close to 3.5 years, and the time from symptom onset to the referral to a bronchiectasis program is close to 10 years, so 9.5 years. So basically, these results actually are pretty consistent with the results that the ELF survey just showed us. If we have this in mind, we should think that a good patient journey should not be like that. Should always take into consideration a timely recognition of the symptoms, so symptoms that are not under-evaluated, but actually taken into consideration. Patients should be continuously supported over especially in the first phase in which they do not have a correct diagnostic label. They should receive a quick diagnosis with appropriate investigation and a specialist evaluation in a proper setting. They should receive a coordinated care that usually passes through the multidisciplinary approach that seems to be the best one for this disease. And then patients should be empowered, so they should be informed, educated, and actively involved in educations, in treatment decision and initiatives like this one that are meant to increase the disease awareness even in the general population. So the first step is actually early symptom recognition. So think about the very key symptoms of the disease. The most common one appear to be chronic cough, so a cough that lasts more than 8 weeks, sputum production, recurrent chest infection, and sometimes even dyspnea, so breathlessness and fatigue might be relevant. It's really important to face the normalization issue. So these symptoms are not normal. They should not be under-evaluated by healthcare professionals and by the patients as well, because this could lead to delayed investigation and missed opportunities for an early intervention, and then increase the awareness, both in the general practitioners, in the medical doctors, in the general population, because the earlier people receive a diagnosis, the best is for the long-term outcomes and for the quality of life of these people. The second one is getting the right diagnosis. So when you have this symptom, it's actually appropriate to access to appropriate investigation, in particular high-resolution CT scans, that is the gold standard for the diagnosis nowadays of bronchiectasis. And then after that, just be evaluated by a clinician with a specific expertise in the field of bronchiectasis, which who can interpret the images, correlate the images with the symptoms that you suffer from, and usually identify a proper plan. And it's really important to understand that the time matters, because every year, every month that the patient passes away from the correct diagnosis actually might have an impact, because the vicious vortex of bronchiectasis actually keeps going and might have an impact on the overall quality of life of these people. And then in a very important moment in this journey is represented by the first consultation in a specific setting, in a specific specialistic setting of bronchiectasis, in which people actually try to address two different domains. The first one is understanding these are conditions, so communication is important just to even understand what are the long-term consequences of this disease, what can happen in their everyday life. They usually ask so many questions. So at least this is my experience with this disease and with people suffering from this disease, is that usually people come with lots of anxiety, lots of fear about their own future. So it's usually important to take some time and talk about what could happen over the next year, and then at the same time make a very clear plan and reassure the patients about what are the plans and the items that can be used to slow disease progression, reduce disease activity, treat some infections, some very specific infection, and everything like that. Usually, it's really important to build a multidisciplinary team around the patient. So it's not a one-man's job. It's usually something that we share the responsibility of patient care with different healthcare professionals. So respiratory specialists are the key figure here, but for diagnosis, treatment planning, and monitoring. But there are lots of different other specialists that might intervene in some cases. For instance, immunologists, for instance, radiologists, for instance, GPs. So primary care, psychologists, nutritionists, physiotherapists that are crucial because of the characteristics that the disease have, and the airway clearance techniques that are so useful in the management of the average patients. Specialist nurses and microbiologists and infectious disease specialists for the management on antimicrobial therapy. So treatment components should be personalized according to the patient that we're facing and the phase of the disease that the patient is facing in a given moment. And they usually rely on airway clearance. They usually rely on antibiotic use for both treating of exacerbation and for long-term intervention aimed at reducing the disease activity over time. And then there are some prevention strategies, for instance, vaccination or recognizing early warning signs that actually might have an impact on the quality of life of people. And at the same time, we usually work a lot on the self-management empowerment. So try to raise disease awareness in people to understand what really is bronchiectasis and how they should approach it. Just have a written plan about when to seek help, when to ask for an urgent medical evaluation, and have an active partnership with other people affected by the same condition. For instance, the ELF patient advisory group that could be useful in cases like that. And this is the way in which we try to treat the three main domains that we have analyzed before. So the daily life impact of the condition, the emotional well-being of people that experience some anxiety about the exacerbation, disease progression, and sometimes isolation or fear about getting exacerbation of pneumonia or other worsening of symptoms. And then when feasible, when the multidisciplinary approach is feasible in the given setting, try to give an holistic support and try to face all the areas of the disease that might be present in a given moment in a patient's life. We usually face a proactive preparation. This is really important in a good patient journey. So we usually try to give people a way to measure their quality of life and try to understand actively and before they happen what an exacerbation might be. So try to predict exacerbation and start the treatment as soon as possible. This is something that we do even for key symptoms, for instance, a change in the sputum color or in the sputum purulence, and sometimes even with hemoptysis. That is a problem that some patients face. And then I have a very specific protocol, a clear management, self-management plan that people might undergo through when they have some specific symptoms to be sure that they face them in a quick and fast manner. And then the follow-up. So after the initial evaluation has been conducted, the patient should be reevaluated over time, should be followed over time to be sure that their condition remains under control, that the disease activity is low, they do not get a chronic infection by some specific bacteria, mycobacteria or fungi, and then if necessary try to change the management of the condition to be sure that it has been treated according to guidelines and to the best clinical practice. Usually over this journey, what patients usually want to is to be heard. So just be sure that they are listened to. They want to share their symptoms, their concerns, their experiences. They want to be believed. And it's actually something that we try to do to the best of our capacity. So we try to empathically share the pathways of these people over time. They want to be informed, so people want to know what's happening, want to know about new drugs that are being developed. They want to know about the therapeutical possibilities that might be available in the next future, and they want to be supported. So they want to be emotionally accepted. They want to be practically listened to and understood at the best way as possible. Because if these conditions are not met, probably the patient journey is not the best as possible. The challenges are actually represented in our perspective by the limited access. So we got there are very few specialized bronchiectasis care clinics over the states or the different parts of Europe. So it's actually important to have an access to a specialized bronchiectasis clinic and have a structure that divides the clinic in first level, second level, and third level according to how much the disease activity is high in a given moment. There's an awareness gap that is still consistent nowadays, especially in the general population or in the primary care, but that is actually getting better over time, according to based on on initiatives like this one. There's a fragmented system, so there might be sometimes a gap between primary care and specialized care. But at the same time, these aspects carry on some opportunities for improvement, especially some improvement for the education, for the referral pathways that can be pretty clear according to specific standard operating procedures related to the centers that manage this condition. And actually, the patient involvement can be helpful to spread the word and to make sure that the general population is a lot more aware of what's happening in the field of bronchiectasis. So basically, this is my idea of how a good patient journey should be, and I'm pretty sure that working together, clinicians, researchers, and patients, we could achieve an improvement in the trajectories of these patients. And thank you very much for listening.
So thanks a lot, Suzanne, for this very interesting survey about this. And really thanks a lot, Mattia, for your brilliant recommendations and point of view from a specialist of bronchiectasis as you are, that provide us with so many information. So now we move to a panel discussion with speakers about patient journeys. And for this panel discussion, Stefano Aliberti will chair the session. So please, Stefano.
Thank you. Thank you, Justine. So I think we have 13 minutes before the break to have this panel discussion about patient journey and some question and answer together with Dr. Arietta Spinu, Dr. Mattia Nigro, Suzanne Menan, Justine, and it's my pleasure now to also introduce Dr. Fiona Musgrove that will join this panel discussion. She's not speaking in this session, but she will join this panel discussion. Dr. Fiona Musgrove is a general practitioner with a special interest in respiratory medicine and bronchiectasis. She works in a large commuter town practice in the Aberdeenshire, and is part of the severe asthma team at the Aberdeen Royal Infirmary. She's currently studying also for her PhD in bronchiectasis. So thank you, Fiona, for joining the panel discussion. Now, I would like to start with a couple of questions that are coming from people I saw in the Q&A box. There's been a lot of discussion about the role of GP, Fiona, in the discussion, especially in terms of patient journey. Your presence here is extremely precious because you can give us a general overview of what is going on in the UK in terms of management of bronchiectasis between the hospital and the community, but also maybe give a general overview on what is going on worldwide. Can you just start with a comment about that, Fiona?
Yeah, thanks, Stefano. It's a pleasure to be part of the panel today. And so I think the most important piece for me as a GP is just for us as GPs to be aware that bronchiectasis exists, and that if somebody comes to us with respiratory symptoms, that we should be thinking about it. So a big part of our training as GPs is asthma and COPD, which we see a lot of. And we know about things like sort of lung fibrosis, but we're not it's not a core part of the learning that we do. Bronchiectasis doesn't feature as much. So I think that the single biggest issue for me is just people being aware that if you have a cough with horrible sputum coming up, then it may be that you have bronchiectasis, and we should be thinking about that much earlier in the process. So I think that's the big piece for me. And I think all of the talks that we've heard so far have reflected that people don't necessarily feel heard or listened to. And I think part of that is because when patients are telling us that they have these symptoms, for lots of GPs, bronchiectasis isn't coming to mind. And so if we don't think about it, then we're not going to refer for the relevant tests, and patients are then going to wait much, much longer for the diagnosis and the treatment.
Thank you. Thank you, Fiona. Now, like now to have Dr. Nigro jumping in with a perspective of a specialist working in the hospital and trying to explain what are the major challenges for us as a bronchiectasis specialist working in the hospital to manage the patient together with the GP in the community. So what actually we would like to optimize and improve in this kind of relationship to have the patient care being really optimized.
So basically, can you hear me?
Yes.
Okay. Okay. So basically, this is a very important challenge in our setting because we are a specialized clinic in the field of bronchiectasis, and usually there might be some gaps with the primary care according to the regional system that we are working on. Sometimes what we do is try to hear about what the GPs would suggest in a given moment, but sometimes we fill the gap. So there are lots of times in which the people that got evaluated in the clinic usually have a very low disease awareness because they do not know about bronchiectasis, they do not know about their own diagnosis, and so sometimes we just take some, especially in the first evaluation, we take a lot of time to explain even what bronchiectasis is by an anatomical point of view, by a clinical perspective, and by the implication that this might have over the lifetime. Is no easy because I think that the Italian system, that is the one that I got more experience with, suffers a lot from this gap between the primary care and the hospital. And so usually it's not easy. And we try to address this, taking some time in the first evaluation. I don't know if I answered the question sufficiently, but
yes. Yes, yes, absolutely. I mean, I see this, this point of view, and I was wondering, and I was thinking actually that it's not just a question of management and pharmacological management, but it's also a question of respiratory physiotherapist. I went through a question by one of a patient living in Germany who is asking about the importance of having a respiratory physiotherapist across different regions of the country. And I think that this is one of the major drivers of the migration of people from one region to another region to seek for management for doctors, but also for respiratory physiotherapists. And we need to fight this kind of migration, having both bronchiectasis specialists and respiratory physiotherapists in different regions within the same countries. So, Arietta, could you please give us a general overview on respiratory physiotherapists distribution in the community, what actually they are doing in the community, how can they help patients in the house and support reclearance and rehab in their settings?
Yes, thanks, Stefano. And I think the points you've made so far is about the communication of the patients, but also the healthcare providers between different settings. So in terms of the community, for patients, it does vary between countries and services, but for instance, in the UK, there are services where you can have home visits. So physiotherapists who visit patients in their home setting to assess them and teach them airway clearance techniques. And there's also a large component of pulmonary rehabilitation. And I think sometimes we do know about airway clearance widely, but not we forget to highlight how important the pulmonary rehabilitation services are. And this is because the pulmonary rehabilitation has two components. It's not only exercise, where you have the group of patients who do gradual exercise for a period of time, but you also have the self-management education. And part of it is airway clearance techniques, part of it is how to recognize exacerbations early, and so on. So these types of interventions you would find from individual physiotherapists in the community, you can actually get them from pulmonary rehabilitation. So if people have access to pulmonary rehabilitation, I think this would be really, really beneficial in how they manage their condition and how they improve their quality of life and symptoms. So the main participation of the physiotherapist would be to tailor things to the individual and see how much exercise they should start with and how they can progress, and also what kind of airway clearance technique is most appropriate for them, depending on how much phlegm they bring up, how easy it is, what kind of activities they do in their daily life, and so on. So it's very variable in the Europe. We've seen that with practices from the patients, but I think if the patients themselves can also push and advocate for some services, that would be really, really important.
Thank you, Arieta. And now I would like to ask a couple of questions to both Suzanne and Justine. Some patients in the chat talked about a lack of knowledge about bronchiectasis among general practitioners, among pulmonologists, among other people they met during their journey. I think this is also a common experience of some of the people you talked with, and maybe with yourself. I was wondering if if you thought about some solutions from your perspective, according to your healthcare system, for us to evaluate and improve in order to solve this challenge.
Well, that's quite a tall order, asking us to tell you how to fix the healthcare system. I honestly don't know. I think the communication between primary care and secondary care is a real issue. And I was interested that Matthew said it was an issue in Italy as well. It's an issue in the UK. I think the way they're trying to solve it in the UK is by giving more information to the patients. So everybody has an app that has all their information on. So you can at least share what your specialist has said with your GP and vice versa. I personally have a printed copy of my referral of my clinic notes from my specialist that I take with me when I go and see a GP, because I see a different primary care physician every time. So my hospital specialist updates my treatment plan every time I see him. So I have a current treatment plan to show my community-based physician when I go with an exacerbation, and it will say the sputum needs to be tested. These are the antibiotics that are recommended based on my current history. So I find that useful because the primary care physician doesn't have to try and find the information on the system or look back or try and contact specialists. They have it written in front of them. And that's over time, that's what I found works well for me. But sadly, I can't fix the healthcare system.
Thank you, Suzanne. Justine, do you want to add something else?
Yes, just to add that it's very important for GPs to listen to the patient's voice. For instance, when a patient has one flu, then another one 2 months later, and so on, to listen and to hear that there is a problem and to address the patient to a pneumologist sooner and not to lose time, because it takes time and it delays the diagnosis. And then when the pneumologist can give a real diagnosis, this pulmonologist provides the patient with information that the patient can share with his GPs. So the GPs must accept that the patient provides him with new information that bronchiectasis is something important, and that it's not only a question of flu number 1, flu number 2, and so on. So really to have a positive circle between GPs and pneumologists to include the patient's voice and experience.
Yeah. So thank you, Justine, Suzanne. Thank you all the colleagues that participated to this panel. Now it's time for a break, and we will be connected again in 10 minutes at 11:30 Central European Times. Thank you all for joining.
Okay, good morning, everyone, for the second part of this conference. So my name is Mattia Nigro. I was one of the speakers from the previous part, and I'm a PhD student at Humanitas University in Milan, Italy. And I'm also an internal medicine specialist working in the respiratory unit of Humanitas Research Hospital. Today, I have the honor to serve as a chair of this session 2 that is all about infections. And I'm co-chairing with Rachel McGill, to which I'm leaving the word for introducing herself.
Hi, I'm Rachel McGill. I'm based in the UK, and I'm a member of the patient advisory group, ELF's group for bronchiectasis. So I was diagnosed with bronchiectasis in 2022, but I'd had it for a long time before that, and it was misdiagnosed as cough variant asthma, which people may be familiar with this concept. And then last year I was also diagnosed with NTM lung disease, so non-tuberculosis mycobacterium, particularly difficult to get rid of bug in the lungs, and one of the ones we're going to be talking about today. So this session is going to be about some of those particular nasty things that live in our lungs and can cause trouble, and for which we have different treatments, different discussions, different research going on. So we're going to start with the patient perspective on this. So we've got 3 patients who are all part of advisory groups with ELF, who are going to have made a little video, who are going to tell us about their experience of having different infections. So we have Justine from France, who you've already seen in an earlier session if you were here. And she was diagnosed with bronchiectasis and NTM. All right, let me just check the date. She was diagnosed with NTM in 2018 and bronchiectasis as well. And she's part of the French NTM organization, Mon Poumon Moyen. And Marichke is from Belgium, and she was diagnosed with bronchiectasis and Pseudomonas. So that's another infection. And Tom is from Ireland, and he was diagnosed with bronchiectasis in 2019 and Aspergillosis in 2022. So they're going to give you their perspective on how it is to live with these situations now.
Okay.
I'm Justine. I'm French. I live in Paris, and I'm a patient living with bronchiectasis and NTM, pulmonary disease.
My name is Marijke. I live in Belgium. I have bronchiectasis and Pseudomonas. I was diagnosed with bronchiectasis in 2011, but I probably have it since I was a child because I had pneumonia and several lung infections. The Pseudomonas infection I got more recently in the end of 2024.
My name is Tom Birmingham. I live in Ireland, and I have what my doctor considers a complex mix of bronchiectasis, Aspergillosis, and severe asthma. And I also have had Pseudomonas infection as well.
I was diagnosed in 2018 after 3.5 years of without knowing why I had so many flus and so on. So the diagnosis of bronchiectasis and NTM was made in 2018 when I had a CT scan and bronchoscopy.
So at the end of 2024, I started feeling a lot worse because at that time my bronchiectasis was under control, but I felt like a lot more shortness of breath, and I coughed a lot more. I had a lot more mucus and it was thicker and darker. And I talked to my pulmonologist about it, and he proposed to take a sputum sample. And a few days later, he called me with diagnosis of Pseudomonas.
Well, my respiratory issues began in 2019 when I was hospitalized and I had cavitating pneumonia. And subsequently, I was told that I had bronchiectasis. Indeed, I had never heard of it until that point. I had regular flare-ups then and ongoing fatigue for the following couple of years. I was being treated for chronic fatigue syndrome. And then in February 2022, I got really sick, and I was on oxygen 24/7 for a couple of weeks, and I brought up a large lump of mucus from my lungs, and that mucus tested positive for the fungus Aspergillus fumigatus.
In my case, my pneumologist isn't able to say if I had bronchiectasis first or NTM first. She's told me that I had the two for a long time, but nothing was diagnosed.
For me, it was clear that I first had the bronchiectasis, and later, because it is more recent, the Pseudomonas.
For me, it was a very lengthy process, and I certainly had to push. I had to push. I knew that what was coming up out of my lungs wasn't normal.
I have a really good contact with my care team and with my pulmonologist, so I talked to him about it, and he immediately proposed to test a sputum sample. And a few days later, he called me with the result, which was not good, but he also came with proposal to try to eradicate it. So I take inhaled antibiotics since then. So there is a slim chance that I can get rid of it.
It's quite confusing because my pneumologist decided to get me in the hospital for bronchoscopy because she wanted to really identify the reason why I was coughing. I had pneumonia, I was losing weight. So with the sputum analysis, she founded the NTM. NTM is always living in my lungs.
The impact is considerable, to say the least. Acceptance is an ongoing challenge because you have to accept that you can no longer do things that you always did and you always enjoyed. For me, the fatigue is immense.
For me, the biggest impact on my life is the time that the therapy takes. So I do the inhaled antibiotics twice a day. I have the airway clearance. I have the physiotherapy. But that means when I have a day at the office, I need to do all that in the morning before I leave, and it requires planning to do it, and it requires discipline to keep on doing that.
I don't have a medication actually, because I had a treatment medications for NTM during 1 year and a half, but it didn't work. Medication for NTM you can't have all your life because it's very heavy, it's very difficult with a lot of side effects. So actually, I don't have any treatment anymore. I have a very strict follow-up, CT scan, blood analysis, sputum analysis. So I try to live normally, but with some precautions.
I would advise people to do their research, but be careful where they do that research. In the case of aspergillosis, the European Lung Foundation, obviously, I'm involved in the patient advisory group there, and that's been hugely, hugely helpful. The National Aspergillosis Centre in Manchester as well. But I had to find all of these myself. My doctors didn't tell me anything about this, so I had to look them up.
Stick to your therapy. It's hard, it's not pleasant, it takes time and effort, but it's worth it.
I would love if the medical profession, thought when they're treating somebody with antibiotic after antibiotic for recurring chest infections and sinus infections, and they're back again and again and again, they should think fungal a little bit sooner, and say, look, could this be fungal?
For example, I liked gardening. I did not wear gloves. I was in the dirt with my bare hands, so I should not have done that. Maybe that is the cause, or maybe that is not the cause, but I regret that I didn't know it and that I didn't take that into account.
Perhaps clinicians could talk more about prevention.
People that I know now that do gardening and all of that, I tell them, wear a mask. Just wear a mask, and it just might stop somebody else from being in the position that I'm in now, where I can only look out at the garden now. I can do nothing. I can do no physical work.
Talk to your patient and make up a plan together with your patient. Not everyone is the same. Not everyone benefits from the same therapy.
Medication is one thing, but nutrition, physical activity, mental support is really important for us.
I'm fortunate now that I have after about 3 years, I finally got a good support service where I'm under the care of an infectious diseases team in one of the bigger hospitals in Dublin now, and they're at the end of the phone for me pretty much Monday to Friday anyway, and that's a great support.
If you have this infection, it's completely possible to live almost normally with NTM. Because you have to be careful to the environment, of course, but it's you to decide that you live with NTM, not against NTM.
I tell people, look, try and stay in the moment, control the controllables, as they say, and try not to worry. Let the medics, do their job. And trust them.
It's not a shame to have this pulmonary disease, so life is going on, so let's remain positive.
So thank you very much, Marike, Justine, and Tom, for sharing your own experience related to the different kind of bronchial infections related to bronchiectasis. So it's my pleasure now to give the word to the first speaker, that is Professor Stefano Aliberti. Professor Aliberti is a full professor at Humanitas University in Milan, and he's also the chief of the respiratory unit of Humanitas Research Hospital in Milan, and he's the co-chair of EMBARC. And today he will give us a presentation about sputum, test results, and treatment. So I will leave the word to him. Thank you very much.
Thank you. Thank you so much, Mattia. Thank you for the kind introduction. I will share my slide. Okay, just give me one sec. Okay. Can you see my slide?
We do.
Yes, great. So I would like to walk you all through the concept of managing the disease through the correct knowledge about sputum. Starting from some data that Dr. Mattia Nigro is about to publish, highlighting the importance of sputum as the most common symptom of bronchiectasis. This is a large study conducted both in Europe and in Asia. And as you can clearly see, that sputum production is the major symptom, together with several other symptoms like cough, fatigue, sputum purulence, weight loss, night sweats, shortness of breath, chest pain, or hemoptysis. If this is true, then we can also try to look at how the different symptoms can interact among themselves. And as you can see by this network analysis of different symptoms in bronchiectasis, there is a cluster here of people of symptoms like cough, sputum production, and sputum purulence. And we recognize these symptoms in the majority of our patients with bronchiectasis. But we also recognize that some patients with bronchiectasis might not have sputum production. They might have some other symptoms like fatigue, chest pain, shortness of breath, weight loss, and sometimes people might also have blood in the sputum, what we call hemoptysis. So in the majority of the patient, cough, sputum production, and sputum purulence are the major symptoms, but there are also patients that are not giving sputum on a daily basis. Now, why sputum matters? First, because sputum sputum is a window on the kind of acute and or chronic infection that a patient might have. Could be a window on the level of inflammation of the airways. It's one of the markers of disease activity, which is a very important concept we as physicians are evaluating every day together with disease severity. And then sputum is important because is a marker of worsening of the situation, moving from a sort of stable state to what we call exacerbation. So how do we evaluate sputum? So we ask our patients to have a general idea about the volume. So some of our patients are measuring sputum in mLs. Some other patients are telling us the volume of the sputum according to sort of spoons, coffee cup, tea cup, or bottle of waters. It's important now to, it's also important to investigate if the sputum is thin or sticky. So we evaluate viscosity, and we also evaluate the color of the sputum. So when we ask our patient to define the color of the sputum, we are using this kind of scale, which is the sputum color scale derived by Maeve Murray several years ago. And according to this scale, we define the mucus being mucoid, mucopurulent, purulent, or severely purulent. And the reason why it's also important for the patient to understand that we are not evaluating a single observation of the sputum, but we tend to evaluate the sputum trends because we know that the sputum color can change from the morning to the evening. Sputum can appear after lunch. Sputum can appear according to specific exercise or sometimes with specific food. So we tend to ask the patient to give us a median evaluation of the sputum in terms of volume and color. Color is extremely important because we know that is a marker of inflammation. This is a study by Peter Hoiminen in 2014 showing that there is an increased percentage of neutrophils. Neutrophils are inflammatory cells according to the color of the sputum going from mucoid to mucopurulent to purulent. And we also know, and these are data we published from the EMBARC registry, that sputum color is correlated with disease activity, but also with disease severity and with quality of life. In this case, measured through a very common questionnaire we are using in the field of bronchiectasis. The evaluation of the sputum, as I mentioned, is important to understand if something wrong is going on. So if the patient is experiencing an exacerbation because the sputum volume is increasing, the sputum thickness is increasing, the sputum is changing the color from white to yellow, from yellow to green, and also worsening of the cough. Actually, these are the criteria that we are using to define an exacerbation. This table is defining exacerbation for clinical trials, so not for clinical practice, but this is just to give you a couple of ideas about the importance of sputum volume and consistency and sputum purulence among the key symptoms that should be present for at least 48 hours and leading to a changing in bronchiectasis management to define exacerbation. Sputum is also important to understand if a special management and treatment, either pharmacological, antibiotics, or non-pharmacological respiratory physiotherapy is working. So if sputum is decreasing in volume, in viscosity, and the color is getting more clear, then this is a good response to the management and to the intervention. The sputum is mainly tested to evaluate the presence of microorganisms. This could be bacteria such as Pseudomonas. This could be non-tuberculous mycobacteria or fungi. The latest ERS guidelines try to answer a very simple question about the etiology of bronchiectasis according to the evidence. How can underlying causes of bronchiectasis be identified? And if you take a look at the standardized testing that every patient with clinically significant bronchiectasis should undergo to, you can see that sputum culture for bacteria, fungi, but also for NTM is among the suggested routine test together with the full blood count, the serum electrophoresis, the screening for Aspergillosis, and the serum immunoglobulins. But sputum is also a treatable trait of people with bronchiectasis. If you look at the most common pulmonary treatable trait that we as physicians are evaluating in a patient with bronchiectasis, infections including chronic Pseudomonas infection and NTM infection and Aspergillus infection are there. And finally, if the patient is getting worse, so if there is a rapid deterioration in terms of symptoms and exacerbations, the ERS guidelines are suggesting to repeat testing for bacteria, fungi, and non-tuberculous mycobacteria to understand if there is a microbiological cause of that deterioration. It's extremely important to have an agreement with the patient about how to collect the sputum. Preferably early morning, after cleaning the mouth with water. Usually we ask the patient to perform airway clearance if it's possible, and then to collect the sputum from the chest, not the saliva from the mouth, through deep breaths and cough. Then we ask the patient to expectorate directly into a sterile container, and this should be thick mucus, not saliva, and then seal tightly, label correctly, and then, if they can, to transport the sputum to a laboratory as soon as possible, within 2 to 4 hours, ideally. And in case if this is delayed, store at 4 Celsius degrees. But we ask to avoid storage of the sputum for more than 5 or 6 hours because this could impact the sputum results. So one important message is that a good sample will give reliable results, and this will help us as a physician to make better treatment decisions. So the way as the patient is collecting sputum is important. But what if a patient does not produce sputum? Because as I mentioned at the beginning of my presentation, there are patients without a sputum production. So it's very important to check at the CT scan if sputum is there, although the patient is not able to expectorate. This is what we are calling mucus plug. Because if mucus plug is there, we want that sputum to be out from the bronchiectasis. And we can do that through mucoactive agents and through a very well done respiratory physiotherapy. So it's also important to understand if a patient is able or is not able to expectorate, although the patient has mucus in bronchiectasis. And among those without sputum production, still we should remind us that the absence of sputum does not mean absence of disease, because some patients might have several other symptoms that are giving disease activity and disease severity. How sputum guides treatment? There are 4 major areas. So we are looking at sputum results because this will help us to decide which kind of antibiotics we can suggest to the patient in case of an acute exacerbation, in case we need to start a long-term suppressive antibiotic, inhale antibiotic treatment, or in case we need to go through an eradication of Pseudomonas, for example. We use sputum also and sputum color sometimes to identify disease activity and understand if the disease activity and the severity of symptoms are driving the decision to start immunomodulatory and anti-inflammatory therapy, like macrolides, for example. Sputum is important when we are doing airway clearance, and we also tend to suggest the use of bronchodilators together with our physiotherapists to improve the airway clearance. And finally, we can manage the mucus through different mucoactive drugs in order to improve airway clearance. ERS guidelines are suggesting to use mucoactive drugs for patients without symptom control, although respiratory physiotherapy is optimized. So these are my, sorry for the typo, these are my take-home messages. So sputum is a window into the lungs, reflecting infection, inflammation, and disease activity. Changes in sputum in terms of volume, color, or thickness, together with cough, are some predictive signs of an exacerbation, and patients should learn during the negotiation with their physicians how to define an exacerbation. Improvement in sputum is a marker of treatment response, especially during an antibiotic course because of an exacerbation. We acknowledge the fact that not all the patient can produce sputum, but we need to look at the presence of mucus plug at the CT scan and do whatever we can to have the sputum out from the lung. Treatment should target both infection and mucus, including the appropriate use of mucoactive therapies. And finally, patients play a central role in recognizing and monitoring sputum changes over time in terms of day-by-day variability, but also as a predictors of an exacerbation. So with this, I would like to thank you for listening.
Thank you very much. Such an inspiring talk and lots of questions in the chat for the Q&A session that we will have afterwards. So I will just introduce the second speaker of today. That is Professor Sanjay Shotimal. Professor Shotimal is an associate professor at the Kong Chan School of Medicine in Singapore, and he also serves as the vice dean for research in the same institution. He's the chief of a translational group that is mainly focused on endophenotyping pulmonary infections, including Pseudomonas, that is the topic of today. So I will just give the words to Professor Shotimal, and thank you for being here.
So thank you, Mattia. Can I check you can see my slides?
We do.
Excellent. So thank you very much. This is always the most exciting talk of the year that I give to our patients, because everything we do, both in clinical care and research, is actually for each and every one of you. So this talk is a high priority one for me. So I call Pseudomonas, which has been mentioned by both our patients as well as many others in the talk so far, as an unwanted guest in bronchiectasis. And these are my disclosures, of which none have any influence over the talk today. I think the patients at the start of the session have already said it best. Infection is clearly important in bronchiectasis. It will remain important, and it's central to both the development as well as the progression of bronchiectasis, and particularly in exacerbations. And really today we're going to focus on one of those infections called Pseudomonas. So I've framed most of this talk in terms of the questions that my patients and patients in general ask their physicians. So who is Pseudomonas? Why does it like my lungs? And why does it even matter? And those are three key questions that patients always ask. So to start, who is Pseudomonas? Well, it's a type of germ. It's a bacteria. It likes damp places like soil, water, drains, etc. Most healthy people, if they were to acquire Pseudomonas, would clear it. But in bronchiectasis, because the airways are damaged, it somewhat gives this bacteria a place to settle. So it is really an unwanted guest in a bronchiectasis lung, and it affects about 1/3 of patients. So most importantly, why does it like bronchiectasis lungs? Well, because if you compare bronchiectasis lungs to healthy lungs, you could see that there are damaged airways and damaged pipes. These airways are wider, they're more bumpy, there's mucus that collects in them, kind of like potholes and puddles that you'd see down a road. And those potholes and puddles are exactly where Pseudomonas likes to sit down, lie, and grow. So why does Pseudomonas even matter? Well, I think for all the patients who've already spoken about it, it matters a great deal. And it's because it causes more frequent chest infections, exacerbations, breathlessness, tiredness, hospitalizations, all the things we don't want. And I think there are a couple of important points to make about Pseudomonas in general. And the first one is that it's a sign that the disease, in this case bronchiectasis, is more serious and needs closer care, but it is not a reason to panic. It's a reason for you to act and have good discussions with your caring physician about how best to deal with this. The other thing I always tell my patients is Pseudomonas is not your fault, right? You haven't done anything to acquire Pseudomonas. It's just a germ, an unwanted guest that takes advantage of what's already damaged pipes in your lungs. So here we get into some of the biology of Pseudomonas, and I say that it's an unwanted guest because Pseudomonas brings along with it what I call a bag of tricks, just like a thief trying to break into your very pleasant house. And two of those bags of tricks are what I call slime houses or slime shields. And I'm going to talk about each of them in turn. So what are slime houses? Well, Pseudomonas is a very clever bug. It settles in the lung, as I've explained, in a bronchiectasis lung because of those potholes and puddles, and it builds what we call an apartment block that it wants to now live in. And that apartment block is very slimy. It's able to stick on the walls of the airways, and we call that in medical terms a biofilm. And so these slime houses promote the formation of what we call biofilms. Inside this gooey layer or biofilm, the reason that they build this apartment block around themselves is because it protects them from antibiotics. It protects them from your immune system reaching them. So it's a way that this unwanted guest stays in a place that they're not wanted, and it's more difficult to get rid of them. The second thing, and the second bag of tricks that Pseudomonas brings us what we call slime shields. And the problem with slime shields is that it causes antibiotic resistance. So here in this image, the Pseudomonas has built a lovely biofilm, an apartment block, protected itself. But in fact, when you try to put antibiotics onto it, it's quite resistant. And it's resistant because it's built these shields around itself. Now, that does not mean that there's no treatments for it. It just means that sometimes the typical treatments like oral antibiotics may not work, and we might need something much more strong, such as targeted antibiotics, in this case, nebulized antibiotics that one of our patients at the start appeared to be on, and secondly, intravenous antibiotics that we put through the bloodstream. The other thing that patients always ask is, what about Pseudomonas, and why are my clinicians not clear about whether I have it or not, and whether to treat it or not? That's a very common question, and it can be quite confusing. And I think the first thing to say is that you need to know if your Pseudomonas has just arrived in your lung or it's been there a long time. That's very hard to say. So sometimes, if your sputum is being monitored, as Professor Aliberti has described, you might catch Pseudomonas early, and therefore you can try to get rid of it. It's quite similar to if you're a gardener, as I'm sure several of our patients are. It's like catching weeds when they're quite small. When weeds are small, they're much easier to remove. However, if Pseudomonas builds and uses their slime houses, slime shields, moves in as a long-term unwanted resident in your lung, well, the focus is it's more difficult to get rid of it and expecting it to fully disappear. And so then the treatment focus is back on keeping it quiet and under control and behaving well, rather than trying to get rid of it completely. And that's very similar to a garden with quite stubborn weeds. You might not be able to get to the bare earth, but with regular weeding, mowing, sowing, and tender loving care, the garden still looks and functions well, but that needs to be maintained. And so if you have long-standing chronic Pseudomonas, that's how we would treat that. And so hopefully that answers a lot of the patients who ask why my clinicians are not clear on whether I have it or not. It's because your doctor's probably trying to work out if it's just arrived or it's been there a long time, and what types of treatments may be suitable for that, because that's different between those two approaches. The next thing is, what symptoms might I notice if I have Pseudomonas? Well, you're going to notice your typical symptoms: cough, shortness of breath, more aggressive, discolored mucus, as Professor Aliberti has described. But I always tell patients, you must recognize the difference between your usual and something that's worse. And that is usually an important signal for the care team to know. And early reporting helps. And the analogy I like to use is you think of your lungs as a car dashboard. Cough, sputum color, breathlessness are all warning lights in this car. And, when you're driving your car and warning lights come up, you bring the car in immediately to be checked. So don't ignore your lungs' warning lights, especially when it comes to Pseudomonas. The other question that patients have asked before is, should I be treated for Pseudomonas if it's only found in my culture sometimes? Well, just as I've explained in the last slide and this one, it really depends on how it's behaving, how long it's been there, and whether it's causing problems. So treatment decisions can be quite variable between patients, and I think we need to appreciate that, and that needs to be a joint decision-making between you and your physician. So Professor Aliberti has already done a fantastic job in explaining to you about why and how we use sputum tests. And so for Pseudomonas, we want to be able to identify it if it's there in the sputum tests, particularly cultures, and that will help us guide us as to whether A, it needs to be eradicated, especially if it's early, or it needs to be maintained more long term because it's been there much longer period of time. Another question that's been asked do we have current medications to eradicate Pseudomonas? Absolutely, we do. But these are a combination of oral and inhaled or nebulized antibiotics. And again, they're recommended especially when we detect it for the first time. So there is a moderate recommendation in the most recent treatment guidelines that's been authored by many of the speakers at this conference, to say that, in fact, if you isolate Pseudomonas, and we know it's your first isolation because your sputum has been monitored, that there is evidence to suggest that we should try to eradicate it. However, there is a much stronger recommendation for patients who have Pseudomonas for the use of long-term inhaled antibiotics. Again, as you've heard a patient in the opening video speak about. So really, to summarize it, I mean, how can we tackle Pseudomonas? And a simple way for patients to appreciate this is I call it the Pseudomonas treatment house. And the house has 3 layers. You have a foundation, you have a first floor, and then you have an upper floor. And really, the first floor, which is the most basic thing, is airway clearance every day. And this is important because this is quite similar to you brushing your teeth every day, flushing your pipes in the lungs every day. And that's to create a situation where your mucus is less sticky, there are less potholes and puddles, and therefore the Pseudomonas is less likely to settle there. So that's the foundation. The second level up is really antibiotics when you need it. These can be tablets, these can be inhaled or nebulized, or these may be intravenous, which I'll speak about in a second. And the concept of how you choose each particular one is that we're not just putting out a fire that's smoldering in your lungs today. We're trying to reduce the hidden smoldering that may be occurring in different corners of the lungs, which you might not notice immediately. And then the upper level of the house is more general protection and follow-up. Vaccines, exercise, good nutrition, attending your bronchiectasis clinic regularly. So I think the Pseudomonas treatment house gives patients a broader view of really how we tackle this particular organism. And all 3 floors matter. And again, the analogy I like to use is if we only rely on floor 1 and 2, which is on antibiotics, and forget airway clearance, that's quite similar to you mopping up the floors of your house that are wet and leaving the taps running. So your floor is never going to be dry. So really, every single floor in this Pseudomonas treatment house really does matter. Now, what about inhaled versus oral antibiotics? This is a common question which patients ask. So sometimes we need tablets, and that's probably what patients are most familiar with. But sometimes we need what we call intravenous antibiotics. And this is where they put a little needle through your arm and they give you antibiotics in a hospital when you have exacerbations, particularly. So it's important to understand that that's quite different to inhaled antibiotics, which are usually nebulized. And this allows, if we use inhaled directed antibiotics, for us to reach those slime houses more directly than rather through tablets or intravenous approaches. And so when Pseudomonas has been in that lung house for too long, we need to start to shift our treatment priorities to a peaceful coexistence rather than trying to evict them from the lungs, which is eradication. So I think treatment priorities change in individual patients over time, dependent on how long that Pseudomonas has been in the lung. So this is one of my final slides, but again, as I said, unwanted guest. Another way to look at it is a noisy neighbor. None of us like noisy neighbors. In fact, we had a very noisy neighbor in our particular apartment, and we've learned to have a peaceful coexistence with them. Now, what and how can patients do that with Pseudomonas? Well, if you think about it, are sitting in your house, quite peaceful, a really noisy neighbor moves in. You could use locks. You could have make sure that things are clean. You could have a security system, and you can have CCTV to keep close monitoring. If we translate that to something with Pseudomonas in the lungs, well, your locks present vaccines that you should be up to date with. The cleaners and the keeping the place clean is airway clearance. The security guards are in fact your antibiotics when you need them and your care team. And then the CCTV is you self-monitoring your symptoms, knowing what's normal, knowing what's usual and what's abnormal. And that's really important. And that keeps you in charge of the building and able to peacefully coexist with this noisy neighbor. So just to finish off, I want to give you a little bit of data on research that's happening in bronchiectasis by our team as well as many others around the world to really better understand Pseudomonas. Like I said, it's a really clever bug and it has a full bag of tricks, and we really do need to study it using research in order to better understand it, in order to better get control of it. So one example is this study that my team did a couple of years ago in collaboration with many of our friends at Embark. And what we did was we looked at patients during an exacerbation and the types of bacteria, viruses, and fungi that existed in their lungs. And that's what you see in this top right-hand corner in a number of pie charts. We took samples at baseline, during an exacerbation, and 2 weeks after antibiotics post-exacerbation. Those pie charts really don't look very different. And that tells you the makeup of bugs that are in the lung at the time a patient with bronchiectasis has an exacerbation. It doesn't change a whole lot. But when we start looking at whether these bugs are cross-talking with each other, it's the same thing as a group of people in the room staying absolutely silent versus them talking to each other. And really what we see many more interactions between these bugs or crosstalk during an exacerbation that likely makes the patient sick. And after antibiotic, that quietens down, but it does not return to the normal baseline. This is very similar to if you're giving a lecture in a lecture theatre, everybody is silent, everybody's listening to that lecture. At the end of that lecture, everybody starts talking to each other. The identity of the individuals in the room remains the same, but the noise level in the room changes. And we call this the interactions between microorganisms. And interactions can be positive, just like we have positive human interactions. We can have neutral interactions, and we can have negative interactions. And in fact, when we look at patients with Pseudomonas, and we look at the types of interactions Pseudomonas is having with the organisms or the other bacteria or viruses or fungi around them, we can see that that is different in different patients. And in fact, in this particular body of work, we found that it could determine whether a patient with Pseudomonas exacerbates more frequently, or in fact, some patients with Pseudomonas who exacerbate less frequency. It may in fact be the way Pseudomonas is behaving and cross-talking rather than the Pseudomonas itself. And finally, this really exciting work that's been published in the last year also shows that different Pseudomonas in different patients at an individual level responds differently to antibiotics. That goes back to the middle of the talk where I said to you that your treatment plan with your care physician has to be quite individualized. And that really depends on how long that Pseudomonas has been there and what's most suitable for you. But what this research tells us is that there are aspects of that Pseudomonas in that particular setting that may respond differently to the same antibiotic. So the antibiotic regime in one patient may respond completely different in another. So here are my take-home messages today, particularly in relation to Pseudomonas. Airway clearance, airway clearance, airway clearance. You don't want those potholes and puddles to be created in the lung so that Pseudomonas can move in and remain there. Take antibiotics only as prescribed. Watch for the warning lights on your lung dashboard and call your care team early. Keep your vaccines up to date, and importantly, if you're on nebulizers and inhaled antibiotic, keep those clean because they can be an additional source of infection. So thank you very much, and I'm very happy to answer any questions that anybody has.
Thank you so much, Sanjay. You're getting very rapturous appreciation in the chat for the clarity of that. Lots of people saying that is the clearest explanation of Pseudomonas they've seen, and really great metaphors going on there and graphics. So thanks so much. So our next speaker is going to talk to us about NTM, which has been mentioned a little bit, and we have loads of questions about that as well. So Professor Nathalie Laurent is a consultant pulmonologist and a clinical infectiologist at the Respiratory Medicine Department at University Hospital Leuven in Belgium, and also a lecturer at the Katholieke Universiteit in Belgium. And her research interests are focused on respiratory infections, particularly mycobacterial infections, of which NTM is one, bronchiectasis, and cystic fibrosis. So welcome, Nathalie.
Thank you very much for the kind introduction and for the invitation. I thought that talking about NTM and bronchiectasis in 15 minutes would be kind of a mission impossible. But thanks to Sanjay's excellent talk, I mean, he has already explained a lot of things that we can draw from Pseudomonas to NTM. Next slide, please. Yeah, sorry, I cannot share my slides myself, so you will hear next slide occasionally. Non-tuberculous mycobacteria, or NTM, or sometimes they're also called atypical mycobacteria, are widely present in the environment. And we are, hence, like environment as Pseudomonas, like soils, dust, tap water, showers, and we are all exposed to. Most of us can clear the infection, and it may occasionally be present in the, occasionally be found in the airways, but rarely that it will cause a persistent airway presence and disease. However, when that occurs, when these non-tuberculous mycobacteria, when they settle in the lungs, they can grow slowly and they can cause lung damage, which is what we then call NTM lung disease or NTM-PD. And this type of bacteria, they mainly affect people with underlying lung diseases, such as bronchiectasis, or those with a weakened immune system. Next slide. So NTM and bronchiectasis, they go together like peas and carrots, a phrase that was used by Dave Griffiths once. So the association between the two is well known, but whether NTM causes bronchiectasis or whether bronchiectasis predisposed to NTM, actually, we don't really know which one comes first. But we do know that bronchiectasis is the key most important risk factor for developing NTM disease, and that is why in the bronchiectasis management guidelines, screening for NTM, so performing mycobacterial cultures on sputum or bronchiolar lavage, is highly recommended. So that is not always very well implemented, as we know from an EMBARC study back in 2019, that less than 20% of people were screened for NTM. Yeah. So about 10% of patients, in about 10% of patients with bronchiectasis, we can find NTMs in the airways. But less than that, like 4%, will really develop the disease. That depends on where you live. Prevalence of NTM lung disease is higher in Asia, in the US, than in Europe, and females have a higher risk of developing this. Non-tuberculous mycobacteria, they are a family of mycobacteria, and they all have a, what I would call, surname. Yeah, so they are different types. And the most commonly found mycobacteria that cause disease worldwide are Mycobacterium avium complex, sometimes also called MAC, or Mycobacterium abscessus. Next. Now, diagnosing NTM lung disease can be quite challenging, and it may take time. And why that is because the symptoms that patients present are not very specific, and the radiological abnormalities on the CT scans may also overlap with the underlying lung disease. Classical symptoms are cough, with or without sputum, like tiredness, weight loss, sometimes fever or night sweats, and some people even have blood in their phlegm. It can be a new onset of symptoms, or it can also be like a worsening of already existing symptoms that do not respond to the standard therapy, and that then trigger your doctor to go and look a bit further. Next. So the radiological abnormalities, they can vary from mild disease, like mild bronchiectasis and some opacities on your CT scan, to really formation of holes. Next. So these findings, combination of these, will trigger the microbiological workup. Next, please. Which means that your doctor will ask you to provide some sputum samples, and this will, he or she will request then mycobacterial cultures. In many centers, mycobacterial cultures are not done routinely. Yeah, bacteria and fungi, yes, but mycobacterial cultures may have to be requested separately. That is one thing. If you find one NTM in an occasional sputum sample, probably doesn't mean a lot. We don't know whether that's just contamination. So we need several repeated positive cultures with the same NTM type. Hence, this diagnosis can take time, and it can sometimes take up to more than a year or even 2 years to actually make the diagnosis. Next, please. Next. Another thing, can you go one back, or one slide back? Yeah. Another thing that is that makes dealing with this infection difficult is that the natural course of the disease can be very variable. Some people, they can remain stable, mild disease for years. Others, they can rapidly go worse. As you can see in the upper row, both patients, 2 different patients, both were infected by Mycobacterium avium complex. As you can see over the years, the upper row lady developed what we call like cavitary disease, whereas the patient in the lower row just actually remained stable. Both have received treatment. So that's another complicating factor. Next, please. Now, how do we manage NTM lung disease? Once the diagnosis is made, your doctor may not necessarily immediately prescribe antibiotic therapy. That is because the antibiotic therapy for NTM lung disease is not just the classic 1 to 2 weeks oral or IV antibiotics. It consists of, 1, a combination of at least 3 antibiotics orally, very often, but depending on the type of NTM that you have in your lung, it may also involve adding an inhaled antibiotics, or even requiring antibiotics to be administered intravenously. Yeah. Then the antibiotic course will not take 2 weeks, but it takes 12 to 18 months, or sometimes even longer, because these bacteria, they are excellent in escaping the immune system. They can hide in cells, they can hide in the biofilms that Sanjay referred to. The antibiotics, they may cause side effects. Actually, they commonly cause side effects, going from stomachache to diarrhea, vomiting, loss of appetite, extreme tiredness. But I mean, these side effects, they can be managed, and they do not necessarily occur in each and everyone to the same extent. But another complicating factor is that we cannot guarantee that with the antibiotic therapy, we can clear the infection. And recurrence, reinfection, is a possibility. So that is sometimes a reason why your physician may say, let's start with what we call a watchful waiting approach, which involves active monitoring of your health condition and decide on antibiotic therapy whenever the need is there. It may help you to postpone the antibiotic course for some time, or which may be months or sometimes a bit longer. Next. So before, like the optimal time, lots of patients ask me, like, so when should I start? Actually, the optimal time to start the antimicrobacterial therapy is not well known. On the one hand, you do not want to start too early for the reasons I just mentioned and the complexity of the therapy. However, you also do not want to wait too long for permanent damage to establish, because then it gets very hard to clear the infection. Unfortunately, to this date, we do not have like one single test to guide us on when treatment should be started or not. So it is based on an assessment of clinical evaluations, blood tests, radiology, etc. Next, please. So there are some things, next, please. There are some things to consider before starting the antibiotic therapy. And one of the key things is like, okay, to what extent does this mycobacteria, to what extent do they affect your general health status and your lungs? As I said, not all the types that we find in the lungs are equally disease-causing. So that may play in the decision. Also, how serious is the damage to your lungs? And what is the risk of this getting worse? Next. Are there any underlying health conditions, such as bronchiectasis or other, that can benefit from some improvement in care? As in, is there any underlying reflux disease? How about the nutritional status? Can we optimize that? Can we work on airway clearance in the first instance? Can we treat other infections? We will do anything to improve the underlying health conditions before starting the antibiotic therapy. And then next is, of course, what to discuss, the doctor, the patient, what can we expect of this antimicrobial therapy? What are the risks? What are the benefits of starting you on antibiotics? And it is very important to set your expectations, to set your goals. Are we going to start this antimicrobial therapy, these antibiotics, to improve your symptoms, your quality of life, or to stop your lungs from getting worse? Or are we aiming to clear the infection, which may be difficult? And all of this, next please, all of this is very much a shared decision-making. And it is very important for you to play a role in this decision. And it may vary over the course on what feels good for you and for your treating physician. Next. Well, this is just a very short and graphic overview of the different steps that we go through. And one of the most important ones is indeed to establish, okay, what is this? How high is the risk of progressing to disease? Next, please. Next, please. That's what we discussed. Yeah, and then this need or wish to start antibiotics. And that process can take months. Next, please. Because NTM lung disease is a relatively rare condition, and because it involves so much more than just prescribing antibiotics, ideally, people with NTM lung disease are taken on by a center with expertise in the field, and by a team of healthcare professionals, different backgrounds, different specialties, doctors, nurses, dietitians, respiratory therapists, who can all support you, your care during this journey, because it is a journey, to ensure the best outcome. Next, please. So my take-home messages are NTM and bronchiectasis, they are closely linked. The diagnosis can be challenging, and awareness among clinicians about this condition can be improved, and routine screening surveillance for NTM can definitely be improved. The management may vary. There are different stages of the disease, and these may require different approaches, and observation is essential. This is a slowly growing, a slowly developing infection, so time can sometimes tell. The optimal management requires a careful, considered therapy of both the bronchiectasis, the underlying condition, and the NTM lung disease. And we do know that a lot more research is needed in this field to look for markers of disease activity, to look for better treatments, shorter treatments, better tolerable treatments. But for the time being, we have to deal with what we have. Next, I'm very happy to share with you that as of this week, the NTM page on the ELF website has gone live, and there you can find some more information, resources for further reading, and I strongly invite you to go and visit this page. And with that, I would like to thank you for your attention, and we'll be very happy to answer some questions later on. Thank you.
Thank you very much, Professor Laurent. We will have some space for the questions after the next talk that is going to be provided by Dr. Freddie Frost. So Dr. Frost is our respiratory consultant and a senior lecturer in Liverpool in the United Kingdom, and he's mainly focused on bronchiectasis, cystic fibrosis, and COPD. And today's talk is about Aspergillus and fungi infections. So thank you very much.
Thanks, everyone. I'm just going to share my screen. Can you see the slides there, Matteo?
Yes. Thank you very much.
Thank you very much for that kind introduction, and thank you for the invite to talk today at this conference. I've seen the conference advertised on social media over the last few years, so it's a real honour to be invited, and I'm very pleased to be here. So my name is Freddie Frost. I'm a respiratory consultant in the northwest of England here in Liverpool, and I'm going to talk about fungal Aspergillus lung disease. I don't have any conflicts of interest or disclosures. So what is Aspergillus? Aspergillus is the most important type of fungus that we think about in lung disease, and it's a common mold, and much like Pseudomonas, it's found in similar places: soil, compost, plant debris, but it can also be found indoor in dust and indoor molds within the house as well. It's important to know that we breathe in hundreds of Aspergillus spores every day, if not thousands, and everybody does this, whether you've got bronchiectasis or not. We're constantly exposed to Aspergillus. It's there in the environment, and so for most people with a healthy immune system and healthy airways, and in fact for most people with bronchiectasis, Aspergillus isn't a problem. It's something that we breathe in and out all the time, but the body deals with in natural ways. But in bronchiectasis, it does increase your risk of Aspergillus becoming a problem. There are some people who develop problems related to Aspergillus. There are over 300 species of Aspergillus, but there's only a few of them that really tend to cause lung disease. So you've already heard me mention fungi, molds, and Aspergillus, and some of the terms can be a little bit confusing, but Aspergillus is a type of mold, and a mold is a type of fungus. But other types of fungus include yeasts and mushrooms as well. So they're a real broad family of things that are found throughout nature and often don't cause us any problems at all. If we look at them underneath the microscope, they look a little bit like this on the left, and if we grow them up in the lab in petri dishes or cultures from phlegm samples or spit samples, then you can sometimes get some quite stark and fancy-looking ones like this, where you get black spores filling the test tube. Now, I mentioned that most people with bronchiectasis aren't affected by Aspergillus or fungus in any way, but some people are, and why is that? And that's because in the healthy airways, so before people have bronchiectasis, we have this tiny cilia that beat and sweep mucus up and out. We've got nice thin mucus that's able to trap bugs and be removed, coughed up and out of the lungs nice and easily. And we've got a good, fully functional immune system that's able to patrol the airways and mop up anything that the phlegm doesn't catch. That means that those natural spores that we breathe in and out all the time are usually cleared within hours and don't cause any trouble. In the bronchiectasis airway, sometimes the cilia can be damaged, but the lungs and airways themselves are always damaged, and so we get thick, sticky mucus in widened airways, and those spores can get stuck. And so rather than being cleared within a few hours, they're allowed to live and grow within the lungs, and that presents a problem to your body's immune system, which has to go in and use a lot of energy trying to mop up these infections, and sometimes that can do more damage than good. So where are you likely to encounter Aspergillus? Well, the main concern is damp and moldy homes, and that's because being exposed to Aspergillus a little bit is okay, but being exposed to high levels for a long period of time is something that we worry about. So high levels are often found in the air in houses that have got black mold on the walls or ceilings, in poorly ventilated bathrooms and such environments. When there's building renovation, particularly lots of earth being moved around, lots of dust being put up into the air, that can be associated with high levels of Aspergillus in the air. Thankfully, building renovation tends to be short term, so things do tend to settle down after that. Compost heaps within gardens, rotting leaves, damp areas within the gardens can also have high levels of Aspergillus, but again, people don't tend to live in those environments, so short exposures can be okay, and many people don't develop any problems from that. There are some occupational exposures that we worry about, so farmers or people working in grain stores, silage. Again, that damp kind of yeasty or fungal environment can mean that these kind of people working in those environments will be exposed to really high levels of Aspergillus. And there are exposures that can change over time. So, for example, the Aspergillus levels in the air will change at different times of year with the season, and there are evidence from a number of different studies now that hospital construction is a particular problem, because often people in the hospital are susceptible to Aspergillus for various reasons, whether that's because of bronchiectasis or their immune system, and so care needs to be taken if there is big ongoing renovations within the hospital. So, thinking about fungal lung disease, and the type of things that it can cause, it's important to stress that there's a spectrum. So there's a spectrum. The first thing that it can cause is sensitization, and that's what you can think of as a minor allergy. This is where your immune system becomes sensitive to Aspergillus, those things that we're breathing in and out all the time. Each time they just cause a little spike of allergy. You might not actually get any symptoms from that. We might be able to detect it on the blood in the blood test, but you might not get any symptoms, and often observation is all that's required in those circumstances. Occasionally, Aspergillus can live in the lungs in the same way that Pseudomonas and some of the other bugs that we've heard about can live in the lungs, but it can also live in the lungs and again not really cause any issues. And if we do see it repeatedly in sputum samples, we want to keep a close eye on it and keep a close eye on you and monitor you in case you do need treatment. But we often do adopt a watch and wait approach. The thing that we worry about is, and the thing that we're kind of looking for is aspergillosis, or an infection or a severe allergy caused by Aspergillus. And the two main types of infection are Aspergillus bronchitis, so that is kind of the equivalent of Pseudomonas living in the lungs and causing problems and needing treatment. So we would be detecting Aspergillus in your phlegm samples, and the bloods would show that you've got some sort of immune response to it. But there's also a more severe type, and this tends to be people with damaged immune systems or on long-term immunosuppressive drugs, where Aspergillus can start to cause its own structural damage and sometimes cause fungal balls or invading different areas of the lungs. There is a severe allergic type of Aspergillus lung disease, and that's the most common type of lung disease that we need to treat, and that's called ABPA. I was thinking about Sanjay's really nice metaphor of Pseudomonas being the noisy neighbor. And I think the way to think about ABPA is Aspergillus isn't the noisy neighbor that's moved in and started playing loud music next door. Aspergillus is the neighbor that moved in 6 or 7 doors down and just does something mildly irritating. Maybe it's park in the wrong parking space on the street, park covering your drive. Maybe they leave their bin out on bin day. Something that when they do it once doesn't really cause you any problems, but just mildly irritating. But the more time they do it, each time they do it, when it gets to the 6th or 7th time, you're absolutely raging, you're absolutely seething, and you're very angry about the whole thing, even though they're not doing anything any different. That's the way to think about Aspergillus in terms of your lungs. Your lungs are seeing the same amount of Aspergillus, usually a very small amount of Aspergillus. We don't usually detect any Aspergillus in your phlegm, so it's not like you're infected with it. But it's each time your lungs see it, they're sensitized to it, that it makes them slightly more angry, and you get this exaggerated allergic reaction. And what that means is that you might get back-to-back infections that seem different to usual and don't seem to respond to your usual antibiotics in the same way. People often bring up a lot of thick, brown mucus, often with plugs, hard plugs or hard casts within it. And you might have more allergic or asthma-type symptoms such as a wheeze. Things that you can do in terms of helping your doctor make the diagnosis is take photos. So I absolutely love seeing photos of phlegm in the clinic, particularly when patients tell me that it's changed or there's something unusual about it. It's often really hard to describe what they've noticed, so photos really help. So there's a photo of a nice thick plug here on the left. Some fungal lung diseases will cause you to have black bits in your spit, and it can be useful to see what that looks like in a photo. But also, if you think you've been exposed or you think you've got mold in the house, then taking photos of it can help your doctor understand what the type of fungus that you might be exposed to or what the burden is, and it can also help signpost you to the appropriate authorities to help you get support for that. I will highlight the ELF resource here that's recently gone on, which really nicely summarizes some research published in Chest article recently from the EMBARK group looking at Aspergillus and bronchiectasis. And in that study, they quite nicely showed that approximately, when you think about these groups broadly in terms of the people who are sensitized to it but not really causing any problems, people who are perhaps colonized and people who have got more severe aspergillosis, it's approximately 6% for each group. So how do we diagnose fungal lung diseases? Well, there's a few main tests that we will do. We'll do blood tests because we can measure how your allergy system is responding in general, but also how it's responding to these specific fungi, with Aspergillus in particular. We'll take samples of phlegm to see if we can grow any of those fungi or molds within the phlegm itself. We'll do CT scans. There are some quite typical changes on a CT scan that can help us make the diagnosis. And we might do breathing tests as we would with other parts of your lung disease to see if there's any asthma there or something that might point us towards you having an overactive allergy system. When do we do these tests? Well, the guidelines tell us that we should do it at diagnosis, definitely. And the reason why is because Aspergillus lung disease can be a cause of bronchiectasis in itself, but also it often requires different treatments. And so knowing from the get-go what you're dealing with, how sensitive you are to Aspergillus, how much you've been exposed to Aspergillus, can be really useful for understanding when things go wrong in the future. But we tend to think about doing them again when things do go wrong. So when there's been unexplained change in infections or flare-ups, and patients are telling us that their chest feels different and not responding to those antibiotics in the way that they once did, that would be a signal for us to have a look at these tests again. It's the same tests again: blood tests, phlegm samples, and a CT scan. We do diagnose fungal lung disease. What sort of treatments do we think about? Well, often it requires no treatment, and much like NTM infections that we just heard before, we can adopt a watch and wait approach and keep a close eye on things. Often increasing airway clearance, again, it might be the only treatment that we need. Occasionally, we need to use antifungal treatments, and these can be tablets, nebulized, or even injections in severe cases. These tablets are generally well tolerated, but people do get side effects sometimes. And the main issue is that they can interact with other medications. And so it can be quite complex for doctors and pharmacists to work out which other medications to stop, reduce doses, increase doses, etc. So they can be quite challenging treatments to use. Often, particularly for ABPA, we'll use steroids. So that might be a long-term course of inhaled steroids, of oral steroids. We will often ask people to increase their inhaled steroid use as well. And very occasionally, we need to bring people into hospital for intravenous steroids as well. So in terms of things that you can look out for, I think the main thing to stress is that most people with bronchiectasis don't get any problems from fungal lung diseases. But if you're worried, then the things to look out for are those recurrent chest infections. Something's changed in your phlegm, persistent changes in your phlegm, not responding to treatments. If you think you have had exposure to molds in a significant way, then it is worth discussing with your clinician and mentioning it to them, because it might not immediately come to the front of their mind at every consultation. But I do want you to remember that avoiding fungus completely is impossible. If you do get diagnosed with a fungal lung disease, you're not alone. And again, as Sanjay said, it's not your fault. There's a degree of luck or unluckiness and chance to this. Photos can help, as can keeping a symptom diary, particularly if you think there's a relationship to being exposed to an environment or, for example, work or a home setting where there might be more fungus around. So I'll finish there and summarize by saying that Aspergillus is a common environmental molds, and molds are a type of fungus. Bronchiectasis creates lunging conditions where fungal lung diseases are more likely to develop. We can diagnose them with blood tests, scans, and phlegm samples, and we can often treat them before they cause serious lung damage. So you know your chest very well. If you think things have changed, tell us, and don't be afraid to bring lots of photos. I love looking through them. So there are now a number of resources out there. The ELF has got some Aspergillus resources. I think Tom from Ireland highlighted National Aspergillosis websites here in the UK, and they do have lots of useful information there as well. So I'll finish there. Thank you very much, and look forward to the discussion.
Thanks so much, Freddie, and thank you everyone for all your many, many questions in the chat. So we're going to move on to them. We are running a little bit late, so we're going to go with our questions until 12:05 GMT, 1:05 Central European time, so we'll still have half an hour break there, but we still need to whiz through them a bit. Just to say, don't worry if we don't get to your question now online, because we are going to try to get them all answered by clinicians and the answers will go up online. So we're just going to have to grab the ones that we can now. I just wanted to draw together a lot of different questions that are on the same theme about infections, which is that I know this is very personal and very individual, but there's lots of anxiety for people with bronchiectasis who have not yet been diagnosed with one of these infections, but also people who have, about what they can and can't do and what they should stop doing. So lots of people saying, should I really stop gardening? Should I give up my allotment? Should I always wear a mask? Should I never go anywhere damp? What if I feel uncomfortable wearing a mask and I can't breathe? And just a more general question, how do we break the cycle of recurring infections if we have these lungs that are always open to disease, and we're doing all the other things? We're doing airway clearance, and we're taking our antibiotics if we're prescribed antibiotics. Do we have to just sit at home doing nothing? Maybe the patients want to give their different perspectives on that too.
I think I can come in on the first question in terms of gardening and allotments, and it really is a kind of case by case basis. If someone has got evidence of sensitization or evidence of Aspergillus related lung disease, then I would advise them to really minimize their exposure, because exposures to high doses or high concentrations we think can exaggerate your immune response and make the disease worse in the long run. But I always say that you can't avoid these things full stop, and you have to live your life as well. And so each patient has would place a different level of importance on, for example, gardening and being in the composter, and that would be something that I would very happily give up. There are other other patients who is really important to them, and so it really is a case by case discussion for you to have with your consultant or physician, I think.
Natalie, would you add anything to that about NTM, about whether people should be avoiding things?
I actually corroborate what Freddie just said. I mean, I tend to not to inform them about a potential risk, but to tell my patients that they should absolutely stop doing something that they really enjoy. I find it very hard. Wearing masks and some protective measures may help, of course, although the evidence is not very substantial to support these measures. So yeah, it's hard, it's individualized, and I would be really honored to hear one of our patient representatives on how they feel about it.
There were also lots of questions for Professor Shotimal about Pseudomonas. I've taken notes of few that were passing by during this speak. There were some people that were asking what are the most effective therapies for disrupting the biofilm shield of Pseudomonas. And there were some other people asking, how do you discriminate between acute infection and chronic infection with Pseudomonas?
Okay, thanks, Matea, and thanks to all the participants who raised those quite important questions. So I think I'll take the second one first, which is it's quite difficult to determine an acute from a chronic. So I think the way you would be able to say it's something acute is when you're seeing Pseudomonas for the first time in somebody who's had their sputum routinely tested. There are many patients who either cannot bring up sputum, as we've talked about in Professor Aliberti's talk, and patients who may not have their sputum monitored as frequently. And that can make it much more difficult to determine whether it's acute or it's been there a long time. What I usually do is if I see it's the first time a patient's had Pseudomonas in their record full stop, I will try an attempt at eradication, and then I will follow that up quite closely. But I will also counsel the patient to explain to them that we hope that this works, and in many cases it does, but that there is a chance that it doesn't work. One, because it's a stubborn particular strain of Pseudomonas, or because it's actually been there quite much longer than we had thought before. It's one of those things that if I take 3 samples on 3 separate days, I might detect it in one and not the other 2. So there's no right or wrong answer to this. It's quite a complex situation that it just reinforces the fact that you need to be monitored regularly. And so even when you're well, it's good to have your sputum assessed on a regular basis. The first question, which is the antibiotics that we use to treat, what we recommend in the guidelines is if you're going to attempt eradication, you would have 2-week course of ciprofloxacin, which is a type of antibiotic, followed by a 3-month course of colistin, which is a nebulized antibiotic. Again, it again varies patient to patient. When we get that sputum sample, we will usually ask our microbiology lab to do what we call a sensitivity analysis on every strain. Patients can have more than a single Pseudomonas strain in their mucus, and each strain may have a different susceptibility to antibiotic profile. And so I think, again, this becomes quite an individual decision on a practical level, even though the guidelines can tell us what would be our first, second, third choice antibiotics.
Thank you very much. There were lots of questions about sputum for Professor Aliberti as well. I've taken notes of a few of them. So there were some people asking how often should people get the sputum tested? And there were also some people asking about what dry bronchiectasis is.
Okay, thank you. So guidelines are suggesting that all patients with a clinically significant disease should have a sputum tested in the process of evaluating the etiology of the disease and to define the microbiology ID card to understand if a new infection or an ongoing chronic infection with any microorganisms is there. There is no consensus on the number of months that should pass between one testing and the other one. So we tend to individualize that according to disease severity and disease activity. But in the majority of the patients we are seeing in a tertiary care centers, we are ordering a sputum test every six months or 12 months in very few patients. It depends on the disease activity, as I mentioned in my presentation. For example, if the patient is deteriorating or is worsening, then we might want to take a look deeply into the microbiology state of the lungs. So I would say it's completely individualized. Dry bronchiectasis is something that mainly explain a condition of the presence of radiologically significant bronchiectasis that does not have any sign of bronchial wall thickness or mucus plug on CT scan, and with a patient having no sputum production. So this means that in that specific patient's sputum is not at this time a trait of the disease. So this patient should be investigated for other traits in order to have a disease control in case of a high disease activity.
Tom, you got your raised hand, so probably you want to add something?
Yes, Matteo, I just wanted to go back to the first question in how we can live life when you have lung diseases, like a lot of the people viewing today have. In my case, as I referenced in the video earlier on, I have Aspergillosis, I have bronchiectasis, I have severe asthma, and I also have Pseudomonas. So it's a great mix. In my case, gardening was my hobby. It was my golf, as I say, and I spent most of my spare time working in a polytunnel and growing organic fruit and veg. I thought I was doing good for myself and my family, but little did I know that I was doing a lot of damage to myself. So I've had to stop all that. It just wasn't worth it. It was damaging me big time. So all that stopped. The door on the polytunnel is firmly closed. I've taken on new hobbies to use up the time that I used to spend there. And it has been difficult. It has been challenging. The impact of this is very considerable. But in my case, I've taken on watercolor painting. I do lots of other things that
I can do sitting at the table. I've also spent a lot of my time in the past year or so working to raise awareness of rare lung diseases like Aspergillosis, because there's a huge lack of awareness, certainly in Ireland anyway. So I spent quite a bit of my time at that. I'd have never believed a couple of years ago that I would spend a nice sunny Saturday on a conference like this, but I'm glad to have it now because of all the things that I can no longer do. I just wanted to throw in that. I think it's important, and I just wanted to thank the presentations here. Have been absolutely superb. I've learned a lot more about Pseudomonas, particularly from Sanjay, and I think it's been really, really helpful because, as I think he said, it is a bugger, and in my case, it's a very difficult one to eradicate. Thank you very much.
Thanks, Tom. Also, just to say, it's a really big subject, the subject of risk and what people are prepared to do, not do. Just to say, we're going to be talking more about that in session 3 as well, so we're going to come back to it. So there was a question about this cycle of inflammation and infection and stress, and I don't know whether Marichka wanted to say something about that. So it was a question about if people with bronchiectasis get stressed, are they more likely to get infections? And therefore, is that something we need to be avoiding more than other people do?
That is an interesting question. I'm not sure if I know the answer to that. It might be the case that we are more fatigued when we are more stressed, and that impacts our our health in general, and also the risk of getting an inflammation a lot faster. I don't know what the healthcare professionals think about that.
Anybody want to come in on stress, the role of stress in infection?
I think we have in bronchiectasis a huge amount of hard scientific evidence that shows that when you're more stressed or when your stress levels or anxiety levels change, you're more likely to get an infection. It's so hard to pick apart changes in stress and anxiety levels that come with an infection compared to the other way around, a real chicken and egg sort of scenario. There are pretty well established biological mechanisms in other diseases where high levels of stress can dampen down your immune system or your immune response, but I don't think we have that level of kind of certainty in bronchiectasis, unfortunately.
I will go with the last one if it's feasible, and then we will close the session. It's probably a question that can be forwarded to all speakers. There were lots of questions about co-infections between different microorganisms. So I would like just to ask, in case you got different bugs like NTM, Pseudomonas, or Aspergillus isolated in a given patient, how do you discriminate which is the most likely responsible for the symptoms deterioration of the people?
I'm happy to take that in first instance, and probably the others can add. We cannot assess which one is the most important, but I would take it pragmatically, as in which one can we treat the most easily. And just to say, if it is Pseudomonas, Aspergillus, and NTM, I would go for the Pseudomonas first, and eventually see what the importance is of Aspergillus in the story, and if the symptoms and radiological abnormalities persist, one could consider, and we culture repetitively the NTM, one could consider that. I would never start with NTM in the first place, just because of the complexity long term of the disease and the suboptimal outcomes with the current therapy.
I'll go next. So I agree completely with everything Natalie's just said. but I'll probably finish on another analogy because I know the patients, well, my patients at least love analogies, and I could see Natalie and Stefano laughing already. So, we all go to parties with our friends, right? And we'll meet the same people at these parties. And okay, in some cases, it's the same person who's the loudest person at the party, right? But in other cases, people can have different forms on different days, and it can be a different loud person on a party in January and a different loud person at a party in May. So I think that's probably the best way to kind of think about co-infections. I mean, I think it's individual. It depends on that party, on the form, on the day. And I would say, as Natalie says, NTM is usually not the loudest one at most parties, but when it gets loud, it gets really loud. It's just like the guy who never gets angry, and then when they lose their temper, it's like, God, that's terrible. It's kind of that kind of situation.
Stefano and Freddy, do you want to add something?
No,
Well, no, you go forward, Freddy.
thanks, Stefan. Just what a fantastic analogy that is. And yeah, I haven't got anything more to add to that. I agree with both of those comments.
Yeah, Mattia, I also agree, and the question is very relevant, and I agree with what Sanjay and the others said. Actually, I don't want to add anything else.
Okay, wonderful. So I fear we have to close the session right now. There are lots of unanswered questions that we will try to answer through the dedicated chatbots. Just have your lunch, and then we will all come back at 1:35 current European time for the next session. And thank you very much for joining us.
Thank you. Bye-bye.
Hello, everyone. I think it's time to start the afternoon session. And I'm Bridget Harris. I'm a patient with bronchiectasis, a member of the European Lung Foundation Bronchiectasis Advisory Group. I've had bronchiectasis for a long time and I live in the UK. And I'll just hand over to Stefano, who's going to introduce himself, and then the session.
Thank you, Bridget, and again, welcome you all after the break. My name is Stefano Liberti. I'm a professor of respiratory medicine at Humanitas University and the director of the pulmonary unit in the Humanitas Research Hospital. It's my pleasure to chair this session, which is the session number 3, making choices to live life well with bronchiectasis, together with Bridget Harris. And then I think, Bridget, we can start if you want to introduce the first speaker.
Lovely, thank you. The first section is a video which has been made by Alan Timothy on traveling with bronchiectasis. Alan was diagnosed with bronchiectasis in 1990, and in 2015 he became the first patient member of the European Lung Foundation Bronchiectasis Advisory Group and shared his experiences in the European Respiratory Society guidelines. Alan's keen to make information for patients accessible and actively contributes to advancements in research and treatment for bronchiectasis. And of all the patient advisory group, he is someone who has a lot of experience of traveling with bronchiectasis. And that's what his video is about.
I'm Alan Timothy. I live in the northeast of England.
and I was diagnosed with bronchiectasis 37 years ago. When I was first diagnosed and I could have normal types of treatment, travel was less of a problem. Even when I started with Pseudomonas infections and I could take ciprofloxacin, it was still relatively manageable. But then I got tendinitis from the ciprofloxacin. So for ciprofloxacin is the only oral treatment for Pseudomonas. And I was on Promixin, which is an easy-to-use nebulized inhaler, and again, travel became much easier. My philosophy is, I am a person that has bronchiectasis, not a bronchiectasis as a person. And therefore I spend my life figuring out how I'm going to make things happen, not why shouldn't I make things happen. You know, I'm fairly happy with the risk, but I offset the risks by the planning. Think about what you can put in the luggage, because if you put in your luggage and it get lost, you've got a problem. But if you put in your hand luggage, you then have to get it through through the X-ray scanners, and that gets worse if you're having to use a hypodermic needle in order to mix the compounds up, which you have to do with the colimycin. So you have no choice but put them in the case in the hold, as they won't let you take hypodermic needles onto a flight. They believe that a patient should have a full life, and it's their job to help the patient have a full life. So I started getting very runny noses on flights, which they thought was down to probably viruses or just reactions to things in the atmosphere. So they've come up with or recommended a nasal spray to take before the flights, which apparently lines the nasal bits to stop things getting into it. So when I come back with a problem from a flight or from a travel, they will actively work with me to go, well, let's try this or let's try that. And they'll sometimes change the antibiotics in the emergency pack. And then obviously I have not gone on trips because I was ill before the trip started. There's no point getting a Riparian infection and a flare-up and then deciding to go on a holiday or a long-haul trip. Even I'm not that daft. Swimming in water of dubious quality isn't on my list of things I will ever go and do. So it's not just the getting there and getting back, it's from these activities, which ones are sensible to do and which ones definitely aren't sensible to do. Long-term sunbathing is a problem because some of the drugs I take are photosensitive. So if I'm just working there, so you're in and out the sun is absolutely fine. But if I then have a few days and I'll think, oh, I'll go lie in the sun, then I tend to end up with a photoreaction to the drugs that I'm taking. So if you need to look at what drugs you're taking and whether there's a photosensitivity in there, and if you are, lying in the sun with them is not a great idea. Fully appreciate people who go, no, I couldn't possibly do that because there's a risk or because something might happen. So my wife is an ex-banker and she's not quite as gung-ho as I am. And she's quite often going, you should be doing that, and what about this? And so I do live in a household with a range of views as to the risks and rewards that go with all of this. Just talk to your medical team first to make sure they don't know of any other reason, and make sure you've got proper health insurance.
So I would like to thank Alan for this great video, a lot of important messages, and maybe we can discuss about those in a bit. But in the meanwhile, it's my pleasure to introduce Professor Anthony De Souza, who is a respiratory physician working in Newcastle upon Tyne in the UK. His bronchiectasis clinics has a team of nurses, doctors, physiotherapists running since 2007. Professor De Souza, alongside caring for patients, is also actively involved in national and international research aimed at developing new therapies, improving our understanding in the bronchiectasis. He's part of the BronchUK, the EMBAR community, and he's an author of a large number of very important papers in the field of bronchiectasis. So, Tony, thank you so much for being with us today.
Brilliant, thank you. I'm just going to share my right. So, I'm going to share my slides now, if that's okay. And put it onto slideshow.
Yeah, we can see the slides.
Sorry, it's just not. Yeah, there we go. I'll make it bigger for everybody. So thank you very much for letting me speak on this. It's a topic I'm really passionate about. Firstly, thank you to everybody who's helped with all the research studies that Stefano's mentioned before. So my job today is really to convince you that traveling can be good for you, but it does take a little bit of planning and control. And in the chat, I've picked up very much that people feel nervous about this. And if it's any consolation, I'm probably going to go on a big other side of the world holiday in the summer as my son finishes exams. It makes me nervous. So seeking help, advice and things are important. The talk also included a bit about vaccination, but I'm going to make that less of a focus in that that specific travel advice for certain vaccines is probably sought, through an expert, and that'll vary on which country you're going on to. But definitely for respiratory protection, we know flu, RSV, pneumococcal, and COVID are things that you're slightly higher at risk when you cluster with people. Living with a long-term condition can knock your confidence, understandably so. But I think it's really important that if you don't challenge yourself, things won't change. And I think it's really important for you, if you're living with bronchiectasis, your carers and family, to get out and enjoy life as much as you can, because that's what we're fighting for you, is to have the best quality of life with no limits. And the next slide hopefully shocks you. So my other job is I work in a home ventilation service. So you can see in the middle picture, this is slides kindly gifted by the patients, but there's somebody with a ventilator, and one of the other slides is somebody with a tracheostomy. So if my other patients can do this, this is a challenge to you. I bet you they did not find this easy, and I bet you it took a lot of work, but you can do it. And they had a great time, and we have repeat offenders, as it were. So people that are going on holiday multiple times with all these challenges. So it's not easy. It takes planning, but you can do it. And I'm going to give you confidence. Somebody's already posted in the chat that ELF has some brilliant stuff. Here's the website address, and here are some bits here. Now, unless you've got a really brilliant screen, I think you're probably not going to read that. So let's zoom in it. Speak to your doctor. And I think maybe in the future version, we need to change that about travel advice and oxygen requirements, because it's not just about this, and I'll touch on that in the next second. If your doctor recommends that you fly with additional oxygen, check the policy. So we do get this position where people want to go on holiday and say, I booked a holiday, what do I need to do? And I think that's probably the wrong order, saying, I'm thinking of going on holiday, I want to go to country X or Y, what do you think about it? Is probably a way to do it. And I also think that Jeanette's talk this morning is beautiful in that we need a community, because actually that community advice, knowing which airport's got a short transfer, which hotel's got nice rooms on ground floors, might be really relevant for some people. So speaking early and getting advice before you book is really important. definitely asking about assistance in the airport. So some of my patients that have flown have said, I didn't know I could ask for that, and actually it was such a long walk that I'm so glad I did. We'll touch on these other parts here about water, flight socks, nasal sprays, and maybe on masks, which might come up. So these are the bits on the ELF website, and these slides will be available later. So I'm not going to put it in, go through every bit in detail, but there is information there. I'm going to touch on some bits that I've learned from speaking to my patients. So I think often it's a good question to ask your medical team, and that may well be the nurses, and saying, if you had my condition, would it stop you from traveling? And you will generally get an overwhelmingly no, I think you should travel. But also it's worth thinking about where you might travel, and also probably important to think of when you might want to travel to that place. So, you know, if you're going to Australia in the middle of the UK winter, you're going to get nicer weather than we have here, for example. There are certain places or destinations that might be less favourable for you to travel to if you've got certain risk factors. Now, bear in mind, even those places that have higher risk factors have patients living with bronchiectasis there. So it doesn't mean you shouldn't go, but, you know, if you were comparing going to, you know, a city break somewhere in Europe, it's going to be a very different set of risks and challenges to you to go into rural Cambodia, for example. Think about what you need to prepare for your travel. And the other thing I think we probably forget about is, will I need to take all of my current therapy abroad? So is there an opportunity to think about having a treatment holiday? And I'll touch on that in the next slide. So here are the things that probably make you nervous, that there are different risks as you go to different places. So this is this is a map of a certain bacteria that we sometimes see. It's often more seen in intensive care, but there are greater levels of resistance in certain places. Some places have higher rates of NTM. I joke in the northeast of England, it's too cold for us to have much NTM there, but there are different places. So Hawaii is very beautiful. I've been. I probably wouldn't go there if I had bronchiectasis. It's a heck of a flight, and they have very damp, humid climate. And I think also Alan mentioned this beautifully. He said, I wouldn't go swimming in dirty water. But somebody in the chat's already commented on atmospheric pollution. So a city break might be fun, it can be tiring, you can see lots of culture, but if you go to cities, particularly where they're more likely to have smog peaks, particularly in the summer, that's going to be much, much more challenging. So this might be exposure in the bottom left to high pollution levels at certain times of the year in a city, or exposure to environmental yuckiness. I ask my patients, please don't go to a steam room or a sauna, no matter where you are, because they're constrained environments. They don't get fresh air coming in, so you're breathing stuff that you probably don't want to breathe in. People with SATs around 90% on the finger clip test, 93 is the top end of the recommendation point, are advised to seek advice because of this little curve here next to Garfield, which basically means that once you get at this point, any small change actually means your hemoglobin saturation falls a lot. And I often describe being in a plane is like being close to the top of Mount Everest. And for some people, that's going to be really challenging. So we suggest that you have a thing called a hypoxic challenge test, which sounds kind of tricky. Why is that important? Because if you drop your oxygen sats and feel poorly, then you have to turn around the flight, and that's not very good for the environment. It's pretty bad for you and your holiday. This bit here at the bottom is actually pretty rare, but it's pretty horrible to have an acute breathlessness attack because you've not got oxygen. So it's pretty rare, and it can be mitigated as a point. So ask if you need a flight test, and sometimes that takes a bit of organization. So what is a flight test? There's British Thoracic Society ones have actually been around for nearly 20 years. The first one was in 2002. But basically they say, think about your patient and give them advice on oxygen. So this is very much about oxygen. It's not about fitness to fly. And that's just a slide I've got here. So we often talk about fitness to fly. That tells you whether you need oxygen in your flight, and that's all. It doesn't tell if you're able to walk up and down an airplane galley or whatever. So it mimics you being at altitude. What does it actually involve, it's really pretty low tech. We give you a cylinder of nitrogen and an oxygen tight mask, so it mixes the nitrogen with room air to mimic less oxygen that you would get on a plane, and that's it. And if your saturations drop, you need oxygen. If they don't drop, you don't. One of the challenges increasingly with everything you pay more for less, very few oxygen, a few airlines now give you oxygen for free. Sometimes you have to arrange a portable oxygen concentrator, and dependent on your healthcare system, you might have to pay for that or borrow one. So that I can't give you specific advice on that element because it will vary from country to country. Our patients, just bear in mind though, if you think, well, this sounds too much, our patients go on their flights with their ventilator on and oxygen. So it can be done. You also need this thing called a Mediform. We have in our home ventilation team, because they're perhaps a different group of patients, had a phone call from the airport saying, can you do a Mediform now, because the person's waiting to board. That was a lack of planning. It created an emergency. Fortunately, our team were very kind and sorted it out for them, but it was pretty stressful. And you know, we give them a battery for that, but you need a little bit time to get this Mediform. This is one of our regional airline Jet 2 providers. So each company will have a slightly different one. It was also beautifully mentioned earlier, talking Alan's thing, is that firstly, thinking about equipment, do I need to take on my baseline treatment? Is there an opportunity for me to have a treatment holiday? And if you're going to have a treatment holiday, should you have a practice? So if you're going to Tenerife from Newcastle in October, could you have a few weeks or a couple of weeks off as a test to see what you're like without it? We know this has happened by accident, partly because we've had international supply issues with these. So do I need to take all of the treatments that keep me steady for most of the year for those 2 crucial weeks on holiday? Maybe not. Have that negotiation with your care team. If I do have to take my nebulizer, will it work? Because the voltage will be different. If I'm carrying needles and syringe, can I take a letter? And I think Alan and one of our other patient experts have had differing experience. So I think even if you do get a letter that says you're allowed to carry needles and syringes on board, I'd probably pack some in your hand luggage and some in your main luggage, just in case the airline says you can't. Also bear in mind, if you're carrying medication, not all of the airport scanners still allow the higher volume of liquid. So particularly if you're taking liquid medicines, to be careful of that. So there's quite a long checklist. It's basically on the European Lung Foundation website, but think about where you're going, what sort of duration of flight. Is there something that's nearly as good that your medical team would advise? And also, you know, peer-to-peer support going. Is there a really big difference between Spain and the mountains and Austria, for example? You know, might be similar, but quite different as a patient for whatever reason. Medical supporting letter. Do I need the flight test? Can I chat through about specific risks or destinations that might make me think about it? Alan mentioned about risk of photosensitization. I'm going to touch on that in a minute. And also, I would really strongly advise not only do you have a travel letter that says, you know, I'm under the care of so-and-so and I should have a needle and syringe for this reason, but also possibly your last clinic letter to explain what medication you're on. And ideally, I think, as part of this prep, you should really be submitting a sputum test so that we know what to put as an advice for anybody that has to look after you if you are unfortunate enough to be unwell. So in the kind of interested time, I'm going to just get you to very briefly look at this. I decided not to get you to vote, but some of you will recognize some of these antibiotics. So the question I'm asking you as a group, which of these respiratory antibiotics, used for other things, of course, increase your risk of sunburn? Tetracyclines like doxycycline or tetracycline, quinolones such as ciprofloxacin, levofloxacin, sulfa drugs such as cotrimoxazole, maybe you might know as Bactrim, etc., penicillins like amoxil, combination drugs, penicillin something else such as clavulanic acid, and the latter 2 drugs are sometimes used in people that are on treatment for NTM, clofazimine and pyrazinamide. So the trick answer to is pretty much all of them, apart from amoxicillin. And we've certainly learned the language really matters. One of our patients got a really bad sunburn and then told us they couldn't understand why they'd got a bad sunburn because they hadn't been sunbathing. They cut their hedge at 12 o'clock to 2 o'clock in July, and their hedge was 60 foot long with their top off. So they weren't sunbathing, but were terribly, terribly sunburnt because they were sun exposed at the peak of the day. So be careful of that. So my last couple of slides, drink lots of water. We want you're going to get dry in the flight. Consider taking flight socks and a nasal spray. And this is based on me listening to my patients and patients educating me, but a few of them now take this medication here. You can see it's very inexpensive and it has some interesting evidence, not for prevention, but once you've got a cold, there's some evidence that it might reduce or shorten your duration of a cold, and it might prevent you getting a chest infection. And I think it's part of a suite of things that we might suggest are worth you considering. People often ask about masks, and the ELF advises masks do help reduce your risk of infections on flights, but it's pretty tricky to be in a 4-hour flight with a mask, and once they get moist inside, they lose some of their protection. So this seems to have worked out in the previous video, and quite a lot of my patients do take this over the winter months anyway, because we're getting exposed to colds when we don't know. So my summary and tips: ask a friend, prepare in advance, don't book and then ask questions. Ask the questions first, and there's some really good checklists there. Definitely think about that medical letter and think about the equipment and the voltage side of stuff. Pack your essentials in the hand luggage, but have a mirror copy of them in your main luggage if you can, and bring us back a postcard and some travel tips for others. So I have some reference, but I just want to encourage you to go out and do it. Once you've done it, you'll think, why haven't I done it for ages before? And remember that picture of my other patient group who are on ventilators that have gone gung-ho and they've done well with it. So thank you and enjoy your holiday.
Thank you very much, Tony. That was really encouraging. Not to travel just because we're scared or haven't done the planning properly. And we might return to vaccinations perhaps in the discussion. And now I'm delighted to introduce Dr. Rita Boaventura, who's going to talk to us about bronchiectasis and environmental impacts. And Rita is a pulmonologist with expertise in asthma and bronchiectasis. She works in a tertiary care hospital in Porto in Portugal. Thank you, Rita.
Hi, Bridget. Thank you. I will just share my presentation. So, thank you for the kind words, and thank you for the invitation to talk about this topic that seems simple, but it's something that worries the patients, and that's worth mentioning in these talks. So I'll talk about environmental impacts. Why is this important? Because we're talking about bronchiectasis. We're talking about a disease of the airways. We have impaired and a vulnerable system in which the disease impairs your cleaning system of the lungs. Why the environment is important? Our lungs aren't sterile, but our environment will have some type of impact in bronchiectasis, in causing some kind of imbalance in this in your lung environment. So this could culminate in flare-ups and more damage to your disease. Since the environment is in almost a direct contact with our airways, the question for our talk today would be, how does your environment could affect our airways disease, and some tips on how to best circumvent it. Why is the environment important? Is the trigger effect. External factors don't just cause discomfort, they can cause physical changes. Everything you breathe in could cause some type of inflammation, some types of mucus production, and culminate in an infectious risk that we will try and talk about it in more detail in our talk today. So what are we talking about? One of the main goals in treating bronchiectasis is to prevent further damage and keep you stable. Known triggers of disease worsening or flare-ups is the exposure to pollutants, so environmental exposure, infectious agents, and irritants that could cause damage to your lungs. One of the nice studies about this that could infer some type of knowledge about your environment is that during the pandemic years, the patients in Embark had a lower impact of flare-ups. So we could infer that this could be some type of this could be attributed to some kind of individual factors, including the mask wearing, the improved hand hygiene, social distancing measures, and the significant decline in air pollution. So this is kind of the starting point for our talk today. What are our modern threats? Air quality. Why is it important to talk about air quality? It's the threat of our modern world. We can measure it based on particulate matter in our environment, and more we know of its impact on mortality and several diseases, not only in respiratory diseases, but in chronic diseases worldwide. This knowledge is so important that with passing years, World Health Organization document has tighter and tighter targets for air pollution and the impact on health. One of the measures of this air quality is the PM 2.5, alongside black carbon, nitrous dioxide, PM 10. But what's the importance of PM 2.5? It is one measure of air pollution, and it's important because it's a fine particulate matter with 2.5 microns in size. That's why it's called like that. That has the capability of reaching the deepest parts of your lungs and increasing airway inflammation and triggering damage and flare-ups in your lungs. It has the capability of inducing a peak in inflammation that could worsen your disease. Some tips that could help could be to be on alert on media warnings of air quality and avoidance and using some type of air quality apps that can help you plan better your outside activities. Another thing with an impact that we know could be the humidity levels. Humidity and cold could potentiate the impact of air quality. So how could you mitigate this in your everyday life? Protecting yourself from pollution and infection. When you're in a home environment, you could use high efficiency particulate air filters that could help you filtrate most of these particles and virus and bacteria. You can avoid window opening in hours of high pollution or allergen exposure, higher burden of allergen in the air. Try and fixing your humidity problems in your home. Try, of course, to avoid some types of sources of irritants, such as smoke, aerosol, working in soil without protection, or trying to bring down the dust levels if it's something that you enjoy doing. When commuting, try avoid walking and cycling near main roads or during rush hour or high peak exhaustion times, and keep car windows closed and use the recirculate air setting. So this is one of your questions, and one of everyone's questions is to mask or not to mask. This is one type of way that you can try and protect yourself from environmental threats. How does it work? The most efficient type of respirator or mask is the N95 or FFP2 because they have the capability of filtrating most of these particulates and microorganisms. So when you know you could be in an environment with high exposure to particulate matter, to allergens, to pollution, it could be one way to try and protect yourself. However, the fitting of the mask is very important because the fitting of the mask, whether you're sitting down, immobile, or doing some type of activity, will loosen the fit of the mask and it could diminish its effectiveness. I brought you this QR code on the best way to try and use your masks and try the best fitting from the CDC page. Other types of questions that you have from protecting yourself from your environment is in terms of leisure activities. Of course, we want you to stay active. However, there could be some things that you could be aware, especially in aquatic environments. Public pools have some things to take into account. The chlorine could be a potent irritant in some airways, and there's some evidence of its impact in developing respiratory symptoms and sensibilization of the airway. Another concern could be the hygiene in these types of public pools. Poorly ventilated indoor pools could raise bacteria concentration and create mists, which will facilitate the traveling of this bacteria back into your lungs. So maybe try to choose well ventilated and outdoor pools when you're trying to do your aquatic exercise. Saunas and steam. I think in this matter, we're kind of all aligned. Why should we avoid them? These types of places are the perfect breeding ground for bacteria, NTM, Pseudomonas, resistant bacteria, because the high humidity plus the warm temperatures are the best places for the growth of these types of bacteria. The steam will help this bacteria to travel back into your lungs, so maybe try and avoid these places. Final takeaways from this talk is to try and be proactive, try quality apps and choose the best times to leave your house and plan your life. Masks could be a help in trying to protect yourself from high intensity pollution or high intensity of exposure in some places. If you can, try to keep your home environment as healthy and clean as possible. Stay dry. Try to skip the steam rooms and places with low ventilation systems. And be aware that this is based on very heterogeneous evidence of impact on the individual. The best policies and the higher impact policies are clean air policies that remain the most effective strategy. So after all this, the most important message is don't forget to stay active, live your life, just keep in mind that there's some things that you could be doing that could help you circumvent these types of environments that could be noxious to your health. And if you can, try and travel to a place like this. This is the north of Portugal, and I invite you to come. We have low levels of pollution, so you can try and visit us. Thank you.
Thank you very much, Rita. This was a wonderful overview. I think we have a lot of questions in few minutes. Now I would move to the next speakers. The next speaker will deliver a lecture on anxiety in bronchiectasis, practical strategies. We had a couple of questions in the Q&A about anxiety and psychological issue. So I think it's extremely relevant, and I welcome Dr. Liz Steed, who is an health psychologist with a special interest in respiratory conditions. Dr. Steed is currently working as a researcher, exploring ways to help improving people's quality of life, especially among those who are living with a chronic illness. Prior to this, Dr. Steed worked clinically at the Royal Brompton Hospital in London, in the UK, and she saw many patients with bronchiectasis. So I thank Dr. Steed for being with us this afternoon. Thank you.
Thank you. And thank you for inviting me to talk today. It really is a pleasure. I'm just going to share my slides. Hopefully that is okay. And we see that as a screen sharing? Yeah, there we go. So yes, I want to talk about anxiety today. What I want to touch on is what it is, how we can recognize it, and also look at some techniques that we can use to manage it on a day-to-day basis. Before we start, however, I'd just like to ask you all a question. And my question is, how often do you experience anxiety in relation to bronchiectasis? And our answers are never, sometimes, often, or nearly all the time. And I'll just give that a moment to see if we can see the results. I can't see the results yet. Will they be coming up?
Yeah, just give people a couple more minutes to answer.
No problem at all. Excellent. Thank you. So what we can see there is a range of answers, but I think what it tells us is that everybody or many people experience anxiety at least sometimes. And that's what I would expect with the condition which causes breathlessness and fatigue. So next slide. So what is anxiety? And we probably know it as an emotion, but also we often recognize it by physical sensations, such as sweaty palms, butterflies in our stomachs, possibly feeling sick, increased heart rate, and of course, increased breathing rate. And what these symptoms actually are is this body's response to a release of adrenaline. Adrenaline is a natural hormone in our body that's released in response to different things. But a key one of them is when we perceive ourselves to be in danger. What our body is doing is getting us ready to either fight that danger or run away. And some of you may have heard of this as the flight or fright response. So now when you have a lung condition, this in itself can feel threatening, particularly when we have a flare-up. And of course, in this context, it's important to follow the advice of your clinician and get help. However, what sometimes happens is although we're not having a flare-up, we can become anxious about the thought of having one, or perhaps the thought about becoming breathless. So the threat and danger we perceive is actually not aligned with how our condition actually is. Now, the problem is this still releases the adrenaline response we talked about, which includes becoming clammy, breathing faster heart rate. And of course, this understandably makes us even more worried. Then quite often a couple of things happen. One, we monitor our body to check how we're feeling. Now, the trouble with this is if we focus in on any part of our body, we'll start noticing things we hadn't before. A common example is somebody talks about nits in the hair or perhaps having an ant run over them. They start to feel itchy. And another thing that can happen is we avoid the situations that make us anxious. Now, of course, this keeps us safe initially, or so we think, but it also means we start missing out on things. And we also don't learn how to cope with situations. So our anxiety tends to get worse. Also, if the thing we're avoiding is our body, is exercise, our body gets a bit deconditioned. So we get out of breath more easily and more quickly. And all these cycles are represented here in a model called the thinking, breathing and functioning model, which is a useful way to understand how our thoughts, feelings, behaviours and symptoms interact. So what can we do about anxiety? And I think the first thing is being open about anxiety, being aware that it's not something you need to hide or be ashamed of, and in fact is very common. About a third of people with lung conditions are diagnosed with anxiety and experience it to the point where it's interfering with their everyday lives. And as we saw earlier, almost everyone experiences it at some point. By being open and speaking with others, we're much more likely to come to understand our anxiety and get the support we need, which in itself takes away much of the power of anxiety. Now, secondly, I think it's to try and learn what anxiety feels like for you. What are the particular symptoms you get? And this is really important. Try and work out what is the difference between signs of anxiety and signs of a flare-up, as sometimes there's overlap, but there will also be differences. And it might be that a conversation with your clinician can really help here, or it may be that a partner or a friend is the one who can notice the difference. Another thing to try and think about is, are there certain things that trigger your feelings of anxiety? Is it when you think about going out of the house or to social gatherings, or is it when you're already feeling quite stressed, perhaps about something completely different? And when you're thinking about triggers, it can also help to try and tune in to the thoughts that are going through your head. We might assume that someone with a lung condition and feeling anxiety has exactly the same thoughts all the time, but this isn't necessarily true. Different people have different worries, and finding out what is behind your own worries or your patient's anxiety is very important. So, although, as I say, anxiety can be caused by different things in different people, there are some areas which are common, and one of those is feeling breathless. And one thing we now know that is really important in whether you feel anxious is how you interpret your breathlessness. So for some people, they'll see it as a sign of danger. They have thoughts they won't be able to control it. They stop what they're doing and perhaps avoid those things in the future. As you can see, if this is like to have a big impact on how we feel and what we do. Now, in contrast, if we move to an interpretation of breathlessness as merely a sign your body is working, it's something you tell yourself you can control, it's just part of the condition and it's nothing to be scared of, it's like to have a far smaller effect. But you might say, well, that's fine if I do know how to control it, but what if I don't? And what I'd say then is the first place to start is to speak to your physio or clinician and get them to help you learn some breathing techniques. These are always helpful, but particularly when you're feeling breathless, when you're anxious. And there's many techniques, and I'm probably not the person to teach you them. One I personally like is window or rectangular breathing, where you make your breath out twice as long as your breath in. And this is good for two reasons. One, it slows down the rapid breathing we tend to do when we're anxious. And two, it means we let enough air out to get fresh air in. I remember a respiratory nurse always used to say, if you've got a full bath and you want to warm it up, you have to let some cold water out first to make room for the hot. And it's the same with our lungs. Another thing we can do to feel more in control is avoid what we call the boom and bust cycle. Now, I apologise if this graph is a little blurry, but hopefully you can see the red lines. And I'm not sure if anyone's ever had this happen, where they've woken up one day feeling good and thought, right, I can get all those jobs I need to do done. You set to it, and yes, you get a lot done. But then in the next few days, you're exhausted and can't do anything. And that becomes really frustrating. So what we want to do is try and change that to, if you can see the green line, where you don't push yourself quite so far until you rest, and then you recover quicker and you feel more in control. And actually what happens is you get more done and you also feel less anxious. So just a note here, one of the best ways to learn these techniques is going to a pulmonary rehabilitation service. I'm sure very many of you will know about this, but basically it's a combined exercise and education program. You go along to it for a couple of times a week for about 8 to 12 weeks, and you can learn all about how to manage with these sort of techniques. Okay, so that's about managing your anxiety when you feel breathless. But actually, this isn't the only time you might feel anxious. It might happen at any point. And one thing people often try and do is distract themselves from their worries. Sometimes people try and use techniques such as watching the TV or reading a book. And this can work, but if our thoughts are very strong, we might find our minds keep wandering back to our anxious thoughts. When this happens, we need to do something that doesn't really give our minds a chance to have these thoughts. And this is when distraction, through thinking very specifically about something else, can help. You may have heard people who try and count backwards from 100 in sevens. It takes our brain a lot of focus to be able to do this. So for this period, our anxious thoughts lessen. Now, of course, not everyone's good at maths, not everyone likes it. So what I would say is choose something that's meaningful to you. It might be something like naming as many dog breeds or football players as you can. And it really doesn't matter as long as it's relevant to you. Now, of course, you can't do this for hours on end. It's a bit of a first aid technique, and it's best used for those situations where you really feel your anxiety is overcoming you, or if you're feeling panicky. The second rather different approach is called mindfulness, which I suspect some people will have heard of. This approach doesn't actually try and stop your thoughts or replace them, but rather recognizes that a thought only makes us anxious because we give meaning to it. If rather than giving meaning to our thoughts, we can just notice them, we don't make a judgment on them, we just let them come and go, and then we very often take away the power. And in many ways, this is a bit like meditation. And although it takes practice, people can learn these techniques and often find them very helpful. And what I've got here on the right are some icons of some phone apps which can help you learn mindfulness, and you might be interested to explore. And so my last slide now. What I've been talking about today are common cognitive behavioural techniques, and they can also include things like keeping a diary to see if there's a pattern to when we feel anxious, asking ourselves, is there any evidence for what we're thinking? Trying to turn around the cycle of avoidance by gently pushing ourselves. And if you do these things, I'd say start small, build on successes, use your support systems. And of course, if you have a more formal anxiety disorder or you feel you need it, it might be helpful to talk to a psychologist. So I'm sorry it's such a short talk today, but I hope this has given you at least some ideas to start thinking about. Thank you.
Liz, thank you very much. That was a really helpful talk. There's lots of strategies that people can use in their daily lives. Thank you very much indeed. And now I would like to welcome Fiona Mosgrave. Dr. Mosgrave is a general practitioner with a special interest in respiratory medicine. She works in a large commuter town practice in Aberdeenshire and is part of the severe asthma team at Aberdeen Royal Infirmary. She's currently studying for her PhD in bronchiectasis. And Dr. Mosgrave, over to you. Thank you.
Thank you, Bridget, for that lovely introduction. I'm just going to share my slides. So hopefully, there we go. So hopefully you can see those now. It's a huge privilege to be asked to talk at this. Thank you very much for asking me. This is a somewhat challenging topic to speak about, but I've done my best to make it practically relevant. So making choices and managing risk. And I think this is a great addition to the session because we've already heard about lots of things where people are having to make choices and manage those risks. So risk from a mathematical perspective is the chance of an outcome happening together with how serious the consequences would be. So it's pure maths, really, the definition. Chance plus possible hazard gives us the outcome. So, but we're not robots as humans. So really, I think the more important question is, how do we decide what risk is? So this is the kind of more human version. So it's what might happen, how bad it could be, how much control I have, how unfamiliar or frightening it feels, and what my own experience tells me. So I think that's a much more useful human definition, and you could apply that to any scenario that might involve risk. So that might involve something terrifically scary like jumping out of a plane, but for many people living with any chronic illness, it might be other things like meeting up in a group with people or going out to do your shopping or meeting up with family and grandchildren. So I think this is a useful way to think about it. And in broad terms, when we think about managing risk, I'm a fairly straightforward, back to basics thinker about things. So you could avoid risk altogether, but it's kind of like the balance of the scale. So if you avoid the risk of something by completely not doing it, then usually you have to tolerate the risk of something else. So if you never go out, you might not get a virus, for example, but you might miss out on lots of very human things that are important to us as human beings. You can accept the risk completely and just throw caution to the wind, but again, that usually has side effects. So I guess what we're probably talking about today is taking steps to reduce risk, which can be a bit of a middle ground. It's very individual. There are never any right or wrong answers, really, and it's highly subjective. So what might feel like the right decision for me is not going to be the right decision for absolutely everyone. I think it's probably quite useful to share a little bit about how our brains can be somewhat unhelpful when we're making decisions. So our brains have evolved to use lots of shortcuts to help us to make decisions. And sometimes those shortcuts can make things more difficult for us. So some of the shortcuts that our brains use are how available is an example of the thing that we're worried about. So let's say that it's, you're worried about maybe getting a virus and having a flare-up or an exacerbation. If you have a neighbor who had a flare-up a few weeks ago, or you've, chatted with someone who's a friend who has one, because that's very available for your brain to pull on, then that feels like it's more risky. Again, we sort of are quite emotionally weighted. So if something is frightening or unappealing, it will feel riskier. But if it's something we're actually looking forward to doing, we will automatically attach less risk to that. The other thing that humans are very good at is that we're not often terribly scientific when we approach things. So we tend to have a point of view about something, and then our brains look for evidence to confirm or not confirm that point of view. So we don't start from neutral. We tend to have an emotional weighting in one direction, and then we look for evidence to support that. Probability neglect is a fancy way of saying if something is more severe, it's likely to be weighted as riskier. Our brains are not very good at analysing the likelihood or the chance of something. So when we are asking what's the chance of that, the question our brain will instead answer is typically how bad is that? So a little bit of maths plus your feelings on things plus your experience gives us perception, and it's perception of risk that is probably more important. This is a magic eye picture. I'm probably showing my age here, but I remember these from sort of childhood and teens, and it's just a nice way of illustrating that perception is key. So if you can see it, which I'm struggling to do at the minute actually, it either looks like a bunch of colourful dots or a shark. So this is a way that you can use to try and walk yourself through the process of perceiving risk and moving towards action. So you're going to start with the feeling. And it's important to name that feeling quite specifically. So feeling a bit worried is a good place to start. But what is the worry about? And you can take a bit of time to drill down into that. And then, does that mean anything? Is it associated with the thing I'm thinking about? Or is it related to the fact that I haven't slept well, or that I'm in the middle of a flare-up, or, there's something else going on in the background? So is that a background feeling, or is it linked specifically with the thing that I'm thinking about? And then you can sort of explore that and think about if there's any mismatch between those two. And that sometimes will help you to gain a little bit of clarity and move towards an action that feels comfortable to you. I guess the proviso here, kind of linked in with the meaning bit, is resting if you're unsure, and discussing with somebody that you trust is often quite a useful addition to this. So sleep on it and have a chat with someone about it. I'm going to use a worked example from this because I'm aware it's a little bit abstract, so an example is probably a nice way to illustrate this. So let's think about, should I go to my monthly coffee morning as an example? So first of all, the benefits are very human things. So when we get together as a group of individuals, we really are social animals. And so that connection and conversation, that ability to share your lived experience with someone who understands it with, with ease because they have some shared experience is really important. And the benefits of that cannot be overstated. And I think we definitely, in a recent example, in COVID times, all very much felt that not being around other people was something that didn't do very well for many of us. The risks, though, are that it's going to be a bit stressful. So there's going to be, you need to be active, you need to be mobile and traveling from A to B. You're going to expend some energy. And we know that if you have any chronic inflammatory problems, there is more of a pull on your battery day to day. And if you expend extra energy, you may then have hours or days to recover. The other key risk I think that's relevant here is that you're exposed to other things that other people might be breathing out, which adds to the stress there. It's probably also quite important just to highlight that the risks of catching a virus or a viral infection and triggering exacerbations varies by personal factors and situational factors. So how severe your disease is, what the current state of your health is. Are you in the midst of a flare-up? Have you just been in hospital? What medications you're on. And these are all complicated variables, and people are very complicated, and you could have, lots of combinations here. So those are the things that are going to be important to you as an individual, but also situational factors. Is this an indoor versus an outdoor activity? Is it in the depths of winter, or is it, peak springtime? Will there be loads of people or only a handful? Will there be children there is often quite relevant in terms of the spread of viruses. And how long? Is this a half an hour event, or are you going to be there for a few hours? So that's all the sorts of things that you'll probably naturally be factoring into your decision making. So using that model, you might just feel really uneasy about this, just really uncertain. And if you drill down into that, that might be a worry about becoming unwell. It might be that a friend became unwell after an event a few months ago and she'd been very poorly, and so you're feeling that that's really high risk. And I guess what that's telling you is that actually there probably is a risk of exposure to viruses at this event. But when you check that, it's not an absolute guaranteed risk. And you can find out some things about the event, like it's indoor, it's not for a huge length of time, there won't be lots of children there, and there is a clear messaging around, please don't come along if you're coughing all over everyone with a virus. And it's going to be in springtime. So this could be any different combination, but these are the sorts of things that you'll be thinking about to help you calculate that risk with a bit more certainty. So it might be that on this occasion you decide to attend because the risk seems lower than you had kind of first thought. So that uneasy, uncertain feeling, actually, when you've dug down into it, you're able to sort of manage that a little bit differently. So that's a very rapid run through, but the summary is that risk is mathematical, but human beings are not, and weighing choices is really complex and entirely individual. So if you can interrogate your feelings a little bit and just dig down into what they mean, sometimes that can help you achieve some clarity in planning your action. If still in doubt, sleep on it, give it some time and reassess, and discuss with somebody that you trust. I would say that's particularly the case, and this is a thing we use in primary care in general practice. If you're hungry, angry, lonely, or tired, your decision making tends to be impaired, and so it's worth just asking yourself if any of those apply. Thank you so much for listening. I hope that's been useful.
Thank you so much, Fiona. This was really good. I think Bridget, we can start our panel discussion. What do you think?
Yes, I think that.
You wanted to be part of our panel discussion?
Yes, please, Stefano. Alan was meant to be here, who provided us with the video at the beginning of this session. Unfortunately, he can't be because of family reasons, so I'll be here as a patient member of the panel.
Yeah. So we went through several important topics that are there in our in patients' real life. We talk about anxiety, we talk about travel, so we talk about feelings and several other aspects. While you were discussing your topic, I went through the question and answer, and I think there is a couple of questions I would like to pose you. One is about working at school. I have several patients who are teachers, right? And they are working with children's daycare, elementary school, and they want to use they ask about the use of face mask. So the teacher category is one of our clusters of patients, and I was wondering if any of you has a specific suggestion for these people.
Stefano, if I can come in, I
Yeah.
certainly see an excess of two groups. So nursery nurse workers are the other group, and teachers, and then I say it with caution, what I call granny syndrome locally in Newcastle. A group of patients with bronchiectasis have been brilliant for ages, and then suddenly they're bad. And Bridget's nodding her head. I think she knows what's coming. And then I eventually get to my Sherlock Holmes question, going, "Have you got new grandchildren? And who looks after them when they're too poorly to go to nursery?" And the hand comes up, and you go, "I think there's a bit of a connection here." So I'd say to my patients, the difficulty, going back to Fiona's beautiful talk, is risk. Do you want to spend time with them versus do you want to be well and never see them? And that judgment is often, I'll say, look, if they've got a cold, you probably don't want them to come because your past history is going to play out again. A lot of them, I think the sort of nasal viral sort of thing, spray, partly came from people saying, well, what can I do? And it was very much what I call a bus cue remedy. I don't know if this works, but you might want to try it. And with experience, I think it might help, and it certainly might introduce a behavior change like hand washing and having the windows open. So I think it's a bundle, but I definitely have had somebody who gave up the job as a primary school teacher and has been loads better, and
Yeah.
she equates it with that, which is
Yeah.
devastating for her, but I think she's much happier with her health now.
And there is another very common question that people are asking is mainly around pets, including cats that bring other animals, either dead or alive, in the house. How should we manage this? Because living with pets in the house is a frequent condition. And Rita, Tony, Fiona, would this affect disease activity, exacerbations? What do you recommend to your patients?
I may start. Since I'm a doctor with asthma patients also, the exposure is very important in some of them, especially if they are allergic, and this is bringing back the talk to specific cases. So if you feel worse when you're with your animals, maybe try to find a nice home for them that is not yours. Because there's not really very good ways around it, because they're in your environment and it's quite hard to keep it out of your environment. But if you don't have any type of allergies, if you don't have this type of problems, and if your pet is bringing stuff from the outside inside, maybe you try to restrict a bit of the hunting ground of they can have, and these are these are point situations in your life. They're not going to increase your risk for your health. And having a pet is quite good for your mental health too. So I would avoid skinning your cat or your dog, and just try to. If you're feeling okay with them at home, it's okay. I think it's not a problem. And the hygiene problem, you can work around it and try to keep it as tidy as possible, and try to keep your environment good for you and your pet.
Fiona, Tony, do you have anything else to add?
Yeah, if I can bring in, I guess, so it's always worth asking them if they go on holiday, did they get better symptoms? So particularly if you're in the UK and we go visit lovely places like Rita's where there's tiles, there's less soft furnishing, and so on, that there's often a clue. I actually say to my patients, I can test you with a blood test if you're allergic to your cat or dog, but I'm not going to do that. And they look at me and say, why is that, Tony? I say, well, I'm only going to do it if it's going to change something you're going to do. If you're allergic to your dog and you're going to keep your dog, we should be spending money to tell us this. We're not going to change things. If your dog passes away and you are making the decision, it's worth doing it. But the other point is, if you have a dog and you're allergic to dog and you give it away or it passes away, it takes quite a while for the allergen to drop. So it's not an immediate thing as well. So that's the other thing is your house is coated in dog, whether the dog's there or not. So it's worth having that discussion. That's why when they go on holiday, you get better because you go to a completely different environment. But the dog being away at your aunt's just to see if that helps, that doesn't work. So it's very hard to get all the antigen that makes you asthmatic or sets you off gone from your house. It's really, really hard to do that.
Yeah. So I have another comment. I would like to take another comment from the Q&A box because not unfrequently people are dealing with some potential risk factors for worsening of bronchiectasis in their work field. And in this case, I want to usually take some important decision with some other colleagues who are expert in occupational medicine and something like that. For example, one of our patients is asking about how to manage windowless AC-dependent office triggering bronchiectasis exacerbation, and these have a very important social impact in the work field. And sometimes they ask us to write, at least in Italy, something very clear for their boss or their CEO or whatever. And in this case, we are sharing this document with the people expert in the occupational medicine. So I was wondering if you have any experience, how can you deal with this kind of situations?
I guess I'll maybe come in there. So it's something that I get asked about not infrequently for various things is sort of, I guess, helping patients with various illnesses explain to their employers in medical terms why they need to avoid things. And it often feels like you're sort of using the patient's experience and just explaining it a little bit in medical language to say that, when they're in this workspace where there's air conditioning, they are constantly unwell and it's likely to be due to the air conditioning. It would seem very sensible for them not to have to be in that environment, for example. So I think in general, there is a poor awareness in the wider world and amongst employers of the impact of working conditions on respiratory health. And I think it often is very much our role just to sort of gently point out that with a few simple modifications, actually, everything is likely to be much easier for the person. So I'm typically quite happy to do that. And I know it's a huge source of frustration for patients who are working and trying to, keep things as normal as possible for themselves.
Tony, Rita, do you have something to add?
Yeah, I had some types of situations in the the disease developed in the workspace, and usually you have to involve other colleagues, like you said, Stefano, from the work medicine to kind of support your theory, because employers aren't always content with just an information from the doctor. And there's some, it depends on the posts. Some posts you can do from remote, and we had some situations like that the people could keep their job and doing it at home, and they could better control their environment. And we have situations in which a simple measuring the air quality of the office, or some type of intervention could help with environment of the workplace.
And Lisa, can I ask you to jump in, giving your perspective on how this disease might impact also not only social life in general, but also work life, because they are coughing, people are maybe in an open space kind of environmental at work, and there is a stigma because they are coughing, and this is generate anxiety or any other feelings. So can you share with us your experience, if you had in your career about that?
Yeah, I mean, I think definitely it's true that for people with very many chronic illnesses, but particularly where you're coughing, etc., that causes a worry, and people are worried about what other people might think about it. I mean, typically, I would say where we can be open and educate people so they can understand that there isn't a danger, that can be helpful. The other thing I think we can sometimes do when we feel anxious is we can engage in a bit of mind reading. So we think we know what somebody else will be thinking. We say we know that they're going to be thinking that, we're contagious or this, that, or the other. And actually, that's not always the case. Sometimes it's about checking out those thoughts as well. But I think there's a real practical balance, isn't there? And I think, it's really difficult for people. But what we don't want to do is people avoid situations so that their life becomes smaller and smaller. So it is learning to use some of those strategies, talking to people, perhaps getting an ally on side that can really help you.
There is another factor which has been briefly touched on, but we've talked about masks, but hand hygiene is really, really important, and is something that all people with bronchiectasis ought to be very vigilant about. Not in the workplace, out and about, wash your hands, use hand sanitizer, because it's almost impossible to stop yourself touching your face and your eyes, and you'll have contaminated them with something. So that's one simple thing. But the other thing I wanted to raise is smoking. And okay, in the UK, we don't allow smoking inside these days, and that's true in lots of countries. But what about secondhand vape smoke? Is there any evidence on that? And obviously we shouldn't smoke as people with bronchiectasis, but yes, what about vaping?
Can someone of the physicians in the panel wants to ask Bridget question?
I'll just
About
display my
vaping?
ignorance. I think we don't know, but basically, Rita's beautiful talk about any particulate matter not being really good for your lungs, and to minimize it. So yeah, if you were going to a place where there was lots of people vaping, and you were bad the next day, I'd go, well, that's why, because there was something in there. Your airways got another reason to be irritable anyway, your bronchiectasis, and this has just worsened it. So I don't think we have good evidence, but intuitively anything, and you look back, history repeats itself. You used to, when you had bad asthma, you used to get sent to Switzerland hundreds of years ago. Cragside, a beautiful place northeast of England, is because Newcastle was full of coal smoke. And it was nothing to do with the destination, it was the absence of pollution. So I think if you can avoid pollution, you can. And I think that fits in with the mask element as well, is I was careful not to say that you should travel with a mask on a flight, because some people go, I won't go on a flight because I don't like a mask. The flip side is if you said, Tony, I think I would be better on a flight with a mask, I'd say, I think you're probably right if you can manage to keep it on. The difficulty I think we touched on before is the fit is quite important. And so, you know, I've obviously got a funny shaped face. I don't fit the mask at hospital, and I had to, you know, go through quite a lot of different ones. So it's not as simple as just buying one. It actually has to seal around you, and then it does get hot. So, you know, it's great for some people if you can use it. If you don't like using it, don't say I can't go on holiday because it'll be terrible. Because, you know, Alan's beautifully said he goes on lots of holidays and he didn't say he used a mask, and I know he doesn't. So I think it's just to give you that. Could it help? Yes. Is it mandatory? Absolutely not. Where would you use it? I suspect I'd probably use it in the flight more than in the queue, but the queue might be as dangerous. I think the nasal spray might be a workaround as well, if that helps, because I know some people were quite passionate about in the chat about the mask question.
Yeah, I wholeheartedly agree with Tony. Yeah, these measures are kind of common sense in some type of these advices are common sense because we know whatever helps you inhale something that could be harmful to your lungs, you should try and avoid it. But the main message is, like Fiona said, you can't live your life expecting the risk and being afraid. And knowledge is power. You know when you should avoid some types of situations. You have some tools that may work for you and may not work for you. And you have to find the balance of what works for you. You're not putting yourself at risk. We know big numbers of the environmental impact on your health, but we don't know individually what works for you. So this is some tips. These aren't mandatory at all. Okay, so it's some tips that could help you navigate your life.
It's
Great.
It's different for everyone, and you're the best judge with having asked your doctor of what risk is okay for you. But remember not to define yourself by your bronchiectasis or any other condition, because you are more than that. And Alan did point that out.
Yeah. So Bridget, it's 2:55. We are perfectly on time. Do you want to close the session and launch the break?
Yes, thank you very much, Stefano. Thank you to everyone for your really, really useful talks and contributions, and Stefano for co-chairing with me. And we're now going to have a 5-minute break, and we will be back at 2:55 at 1:55 GMT and 12:55 CET. Is that right? No, it's not.
Yeah, no. It's I think it's 3 p.m. Central European Time and 2 p.m. The UK time.
That is quite right. Thank you, Stefano.
No, my pleasure.
Hello, I hope everybody is back now. I'd like to introduce you to session 4, Advances in Bronchiectasis, that myself and Professor Tony de Souza will be leading. For those who may not have heard my introduction this morning, sorry, I'm a patient with bronchiectasis, hence I've got a frog in my throat. Excuse me. I have asthma, bronchiectasis, chronic sinusitis, and also I'm diagnosed with yellow nail syndrome, which is also associated with those conditions. I'll hand over to Tony now, and I hope recover my voice.
I was so tempted to jump in there, Suzanne, and thought that would be so typical of a doctor to talk over a patient, but I did think your poor throat needed the rest. So thank you so much to everybody. It's been an amazing day already. I've really enjoyed the sessions. I'm Tony de Souza in Newcastle, and we're going to round up with, I think, 2 brilliant sessions, which have elements of understanding and listening to patients, and then James is going to be talking to us in the future. So I'm going to pass the floor over to Eliza, who's going to talk to us, who's from Greece, and Jen Pollock, who is based up in Dundee, who's going to tell us about your story through your survey. So I'm really looking forward to this. Thank you.
I'll share my screen.
Yeah.
There we go. Okay, everyone can see the slides? Perfect. On you go, Elisa.
Great. Okay, so hello, I'm Elisa. I am a member of the Patient Advisory Group for Bronchiectasis of ELF. And I'm just going to give a very short introduction to the findings of the Untold Stories of Bronchiectasis Patient Survey that Jennifer is going to present just after me. So can we? Yeah, great. So I'm here just to highlight that this was a patient-driven survey. It was developed by the Patient Advisory Group for Bronchiectasis of ELF and Amberg specialists. It was open from June to October 2025. It was translated into 8 languages, and this is the first time that it's going to be presented. Can we move the slide? Okay, so this was a survey that was literally based on our own questions as patients. So these were questions that were coming, and we didn't really have an answer. These were questions that research had not really get in details, or in some points we really didn't have anything. So it has to do with gut health, fertility and menopause, coexisting condition, and the use of herbal and complementary therapies. Now, I'm pretty sure I saw questions on such subjects today on the Q&A box, and I think it's very common to see such questions in our ELF events that have to do with bronchiectasis. I think that it has to do with many issues that we already discussed today. For example, the search for complementary therapies might have to do with late diagnosis or difficulties in finding a way to manage the condition. We also talked today about antibiotics and their side effects. And so gut health issues may or may not sometimes be connected to some of that side effects. And so it's such kind of questions. It really has to do also with anxiety, and not having answers to these questions, I think makes anxiety even higher. So I think this was a great example of partnership between physicians and other specialists and patients. So today we are Jennifer is going to talk for every aspect of this, besides the complementary therapies that we are going to present it separately on a different case, because it was more difficult to analyze. But we want to say that we received 629 responses from 25 countries, and it was mostly from females. Can we move the slides? Yeah, it was mostly from women and aged 56 to 73. And now I will give the floor to Jennifer in order for her to share more about the findings. Thank you.
Perfect. Thanks, Elisa. So yeah, I'm going to give you a run through of the results that we got from our Untold Stories survey. So the first thing that I think is really exciting about the data is we asked about disease severity. So we asked the patients to report how they felt their disease severity was on a scale from mild, moderate to severe. And when we asked this, we found that most people reported themselves as mild or moderate severity. However, when we asked about the impact of bronchiectasis, most people actually responded and said that they felt that their life was moderately or significantly impacted by their bronchiectasis. And this is a really important finding because it suggests that disease severity does not correlate with daily burden of disease. So this is a really important finding. It highlights that severity and impact are not the same thing. So when people are asked to rate their disease severity, they often think in medical terms, such as how bad are my symptoms? How do my symptoms compare to other people's symptoms? Am I hospitalised often? Do I have Pseudomonas? And importantly, what have my doctors told me about my severity? But when they're asked to rate the impact of their disease on their life, they think of other factors, such as daily fatigue, breathlessness during simple tasks, the social limitations of the condition, things like time-consuming treatments like airway clearance, and also the emotional strain of their condition, so anxiety about flare-ups and so forth. So this can really create a disconnect, and we do see that here. But these factors don't always make the disease feel severe medically, but they can heavily disrupt daily life. And again, that's what we see here. And as I said before, this is a really important finding as it pushes doctors and researchers specifically to look beyond clinical severity and highlights the importance of patient-reported outcomes and asking about quality of life and all of that in the management of bronchiectasis. So that's something that we can report back to doctors about so that everyone's getting the care that they deserve. And when we look a little bit closer at disease severity, we found that the self-reported disease severity correlated with common markers of disease severity. So these included things such as infection with Pseudomonas and exacerbations in the previous year. And when we grouped people by their reported severity and looked at whether what their Pseudomonas status was, so this is the table on the left, and what their previous exacerbation history looked like, which is shown on the right, we found that many people who report themselves as mild or moderate severity actually report having these severity markers. So you can see that quite a high percentage of people that reported themselves as mild or moderate had some sort of Pseudomonas infection and also had 3 or more exacerbations in the previous year. So this may be for a number of reasons, but this may be because people have normalised their symptoms, so they've just got used to having exacerbations and therefore they don't see it as a marker of severity anymore. So this can mean that people delay seeking treatment or they might not report worsening of symptoms to their doctor, and this could impact the care that they get. It's also important to consider that these markers of severity have been shown to indicate future risk of having an exacerbation. So if people feel well despite having Pseudomonas or maybe having multiple exacerbations, they may regard themselves as mild, but they can be, so that could mean they're maybe less adherent to treatments like their airway clearance. So it's important that even if you do feel well, you continue to follow your management plan. We also, in this instance, saw that people who reported increased severity didn't have these clinical severity markers. So this is shown in the green boxes. So this may highlight that these clinical markers aren't enough to capture the full story and that perhaps other symptoms may be making these people feel severely unwell. And again, it's important for clinicians to see that just because a person maybe doesn't look severe on paper, that doesn't mean that the person doesn't feel severely unwell and that their experience as a whole needs attention and certain treatments. So again, this just highlights that people with bronchiectasis perhaps view their disease differently compared to how doctors tend to view disease severity. Well, we also asked about antibiotic use, and when we looked at regular antibiotics, we found that about 30% of people reported taking regular antibiotics, with the most common type being oral antibiotics, so things like macrolides. And it's important to note that our new European treatment guidelines for bronchiectasis recommend regular antibiotic treatment for people who are having 2 or more exacerbations per year, and also those experiencing 1 exacerbation but with severe daily symptoms. So when we looked further at this, we found that of those experiencing 2 or more exacerbations in the previous year, approximately 60% were not receiving a regular antibiotic. And likewise, the people that were experiencing 1 exacerbation with moderate to severe symptoms, almost just over 70% of people reported not receiving a regular antibiotic. This is really important because it shows that many people with bronchiectasis aren't receiving treatments which may benefit them. And this is again something that we can report back to doctors about to try and, keep doctors or make doctors, follow the treatment guidelines, sorry. We also went on to look at coexisting conditions, and we found that coexisting conditions are common in bronchiectasis. So approximately 80% of people reported having at least 1 coexisting condition. And the most common conditions were other lung conditions, gut conditions, and heart and cardiovascular conditions. And this may be slightly biased by the fact that gut health was a key topic in our survey, so more people with gut conditions may have been more inclined to take part in the survey. But overall, the frequency of these conditions is roughly what we see in the EMBARC registry, so it seems to make sense in that regard. We also found that just over half of people that had a coexisting condition felt that their condition was related to their bronchiectasis, and that 1/4 of people who have a coexisting condition don't see a specialist for at least one of their conditions. So this was the main takeaway from that most people with bronchiectasis do actually have a coexisting condition, but almost 1 in 4 don't receive specialist care for whatever their coexisting condition is. And we know that bronchiectasis is a complex condition, and it can be the cause of other conditions, or it may be made worse by other conditions. And no single doctor can address and treat all areas of the body effectively. So it is important that coexisting conditions are effectively managed to make sure that everyone is receiving the most appropriate care. And this is another really important finding that we're excited to share with our primary care doctors and colleagues, as these are the doctors who are most likely and most often to refer patients to specialists. Now on to gut health, we found that almost 1/3 of people with bronchiectasis reported having some sort of gut issues, with most people, or the typical number of gut symptoms per person, being 2. And the most common gut symptoms were reflux, bloating, and constipation. And for reference, other studies from the UK, the US, and Denmark have suggested that a general adult population, around 61 to 86%, experience gut symptoms. So it seems like bronchiectasis patients aren't disproportionately affected by gut symptoms. However, reflux in these general adult population studies was a lot lower than what we found in our survey. So it somewhat suggests that reflux is perhaps more common in bronchiectasis. And we also found that of those who reported gut symptoms, almost 1/4 thought that their gut symptoms worsened during exacerbations. Their gut symptoms were only present when they were taking antibiotics, and about 18% believed that their gut symptoms were linked to their bronchiectasis or their treatments. So this suggests a link between bronchiectasis and gut symptoms, at least in a small group of people, which requires more research. And there was clearly a burden of gut symptoms in bronchiectasis. So we found that a lot of people reported that their gut symptoms significantly impact their daily life. They take medications for their gut symptoms, they try probiotics and they modify their diet, or have even sought herbal supplements and complementary therapies. Clearly, gut symptoms are a burden in bronchiectasis, particularly reflux, and these gut symptoms are common, and research is therefore needed to understand the relationship between bronchiectasis and gut health a bit better, but this survey provides the basis for that. And lastly, we looked at reproductive health in menopause. So approximately 21% of menopausal and postmenopausal respondents reported symptoms changing during or after menopause. And most people, most of the 21% did report a worsening of their symptoms. The most common symptoms were fatigue, cough, and frequency of exacerbations. And for reference in the wider community, evidence does seem to suggest that among those undergoing menopause, they have a faster loss of lung function. However, we don't really have a lot of bronchiectasis specific evidence on this. However, I did find one survey of women with COPD and bronchiectasis that found that nearly 1/3 of postmenopausal respondents also reported worsening of lung symptoms. So our survey is in line with this, and it seems to suggest the same thing. This somewhat suggests that menopause may potentially worsen respiratory symptoms, at least in a subset of people with bronchiectasis, but more specific bronchiectasis research is needed. And finally, we just touched a bit on fertility, as there's a lack of clear information on fertility and bronchiectasis out with the PCD community. And we found that when you exclude those with PCD, only 14.9% of people with bronchiectasis reported fertility issues. And this is around about the same as the World Health Organization reports for the global adult population. So it doesn't seem like bronchiectasis patients are disproportionately affected by infertility. But it is important to note that this data may possibly be somewhat biased by the fact that many people with bronchiectasis develop their condition later in life, mainly after childbearing age. So perhaps we need a study in those who develop bronchiectasis earlier in life, excluding those with PCD. So that was just a whistle-stop tour of some of the findings. But just to somewhat conclude, we found that patient perceptions of severity don't always align with clinical disease severity markers, and this may affect the clinical management that patients receive. Many with bronchiectasis don't receive the treatments which are recommended for them by the European bronchiectasis guidelines, so this is something that we need to address with our doctors. Around 1 in 4 do not receive specialist care for their coexisting conditions, and again this creates challenges for effective multidisciplinary care in bronchiectasis. The frequency of gut symptoms appears similar to the general population, but more research is definitely needed to understand the link between gut symptoms and exacerbations in bronchiectasis. And we also found no clear effect of bronchiectasis on fertility or symptoms of menopause. But it did suggest that menopause may worsen bronchiectasis symptoms, at least in a small subset of people. And finally, I would just like to say thank you to Rachel, Eliza, Donna and Anna for they're members of our patient advisory group, and they helped create the study, as well as Jeanette, Mikhail, James, our EMBARC committee, and all of those and all of you who took part and shared our survey. And yeah, thank you for such a wonderful response.
Amazing. Thank you so much, Jen and Eliza. Amazing. Congratulations. We're going to be taking questions later. You probably see my background's changed. I got kicked out, some Zoom malfunction, so I'm sorry I don't have the official background on. Suzanne, I know your voice wasn't so good. Are you happy for me to introduce James?
Yeah, please do. I'm working on it, but I'd like to keep some for the Q&A session.
Brilliant. So I'm delighted to be part of today, part of today has been brought about by colleagues like James and the LF pulling this programme together. James is a good friend. We've known each other for a very long time. I'm absolutely confident bronchiectasis wouldn't be anywhere near as advanced as if it wasn't for James's passion, enthusiasm and his leadership. James is BLF Professor of Bronchiectasis. Many of us will know him from Dundee, but he's recently relocated to Oxford, part of the Tartan invasion, just like me in Newcastle, quietly creeping across Hadrian's Wall. So, James, I'm really delighted to hear your talk about a year of progress in bronchiectasis. And again, thanks for your leadership in the field.
Thanks so much, Tony. And it's been the most wonderful day. So thank you to all of the speakers. And we've just passed 200 questions answered in the Q&A. So please do keep them coming, because we get so many amazing insights from being able to answer your questions. Ordinarily, I would feel a lot of pressure from a title like A Year of Progress, but actually this year we have made enormous progress. And so I think it's a real privilege to be able to give this talk at this time. These are my disclosures. I always start by saying we do some of the studies, the research I'm going to show you with drug companies, some sponsored by Embark. And so we are involved with some of these companies. And I'll talk about some of the medications that we've been working on. So what an incredible year for bronchiectasis. It has been extraordinary. If you told me 5 years ago or 6 years ago when we started doing these patient conferences that in that short time we'd have the first licensed treatment for bronchiectasis, but also a lot of new treatments coming through in earlier phase of trials, I wouldn't really have believed that it could move that fast. So although there's always challenges along the way, it's always important to take a breath and just think how far we've come. A major milestone in the last year was the approval of brensocatib, which I'll talk about later, as the first approved therapy in the US and in Europe and recently in the UK. The other thing that's important is we've had a big change to how we think about management of the disease with the publication of the ERS guidelines. And I'm going to focus a little bit on that because that also links into some of the things that Jen said in her talk with Eliza around not everybody getting the treatment that they should be getting. And that's kind of where I'm going to start my presentation around the guidelines. Some of you will know from previous talks of mine that I love movies, and I always kind of do something with movies. This is an old movie, Sliding Doors, with Gwyneth Paltrow, and the idea of the film is that she misses a train home, and so her life splits off in two different directions, and you get to see how life develops in two different directions. And I'm going to do that with illustrating how things that happen early in the disease can have an impact on people with bronchiectasis. I also love this movie because along with Gwyneth, the hero of the story is obviously a Scottish guy. So let's go with this. This lady starts coughing after a nasty infection in 2020. Initially diagnosed with asthma, some of our data says around 25 to 30% of people with bronchiectasis will be misdiagnosed with asthma before they get their bronchiectasis diagnosis. So this is common. Tries inhalers, but the cough comes back. Then has repeated nasty infections through 2021, 22, 23. Keeps on having these episodes where things get worse, has antibiotics, gets better, but it always comes back. So the GP gives the courses of antibiotics, but the cough always comes back. Tried other medications, stronger inhalers, still not working. We're now 5 years down the line. She has a terrible episode of breathlessness, feels like she can't breathe. And at that point, sees a respiratory consultant. A CT scan shows quite extensive bronchiectasis. Her lung function test shows a lung function of about 60%, meaning she's lost about 40% of her lung function, and a sputum sample shows Pseudomonas. This might come across as a bit of a depressing story, but just like the movie, there's always a happy ending. There are very good treatments that we have for bronchiectasis, both for Pseudomonas and also for chest infections like this. And so she started on the appropriate treatment. A long-term antibiotic called azithromycin 3 times a week, and airway clearance, has a really good improvement, and the chest infections get better. But she has been left with a bit of damage to the lungs, and that's the bit I'm going to focus a bit of the talk on. So imagine we split it the other way. What would have happened if the diagnosis had been made a bit earlier? Initially diagnosed with asthma, tried the inhalers, but then the chest infections start. The 2 chest infections happen. We get an earlier diagnosis with a CT scan. Started on airway clearance, advised to exercise, look after lung health at that stage, 5 years earlier. The outcome, she still has episodes. She still may develop the Pseudomonas later, but the lung function is much better at this stage. The quality of life is much better at this stage. The medications still work, but the intervention has happened earlier, meaning that the outcome is better. So diagnosis early really matters. And unfortunately, 50% or more of our patients, it takes 5 years or more for them to be diagnosed, and 1/4 it takes up to 10 years. That's unacceptable and something we need to fix. And so that's why I'm focusing a bit of the talk on the new research, talking about why we need to treat people earlier with treatments that are effective, really following on from what Jen said in that survey. Because we have quite good treatments. In our guidelines that were published just in December, we strongly recommend this 3 times a week antibiotic tablet called azithromycin, which is anti-inflammatory and also helps to control infection. And I'll show you data in the next few slides that helps to stop the disease from getting worse over time and stops those flare-ups. We also strongly recommend airway clearance, and that's been covered a lot earlier. We strongly recommend exercise, which can also help to control flare-ups and improve quality of life. And for some people, nebulizers containing an antibiotic are an option. And in the guidelines, we recommend not waiting until people get very sick before we start these treatments. We know that certain types of bronchiectasis, people with certain infections like Pseudomonas, and people with nasty symptoms, coughing up a lot of sputum, for example, are likely to get worse over time. And so the big change in the field over the last year with the publication of these guidelines is we're looking to be much earlier with treatment, like that second case that I showed you. Diagnose earlier, start earlier, and treatment will be more effective, and the outcome for patients will be better. Another way of looking at this is prevention is better than cure. We don't wait until we've got nasty gum disease or our teeth are falling out before we start brushing our teeth. We do it every day to prevent problems with our teeth. And the same is true with the lungs. What happens in bronchiectasis is the airway tubes these are the airway tubes here. The airway tubes take the air in and out. This is a zoom in. They get blocked with mucus. When they get blocked with mucus, the air can't get in, get a thing called hypoxia. And then inflammation comes along, these things called neutrophils, and that causes damage to the lungs. And that is what drives progression of the disease. If we unblock those airways earlier and stop that inflammation, then airways are not going to become damaged. The bronchiectasis is not going to be quite so extensive. Okay? Another way of looking at that is that we now know from recent research, so the trial I'm going to show you later, which is called the Aspen trial, measured bronchiectasis patients' lung function over a 1-year period, a thing called vital capacity. It's called that because it's literally the air of life, the amount of air you can get in and out of your lungs. A normal person's lung function will decline by about 20 to 30 milliliters per year. A person with bronchiectasis, according to the data from that trial and other data, declines by about 80 to 90 mils a year. So over a 10-year period, if you can extrapolate that over a 10-year period, a patient who's having lots of chest infections and doing badly with their bronchiectasis could lose up to 1/3 of their lung capacity. That's why we need to prevent that from happening. And the other way that you can measure whether the disease is getting worse is by looking at a CT scan. So you can see these areas of damage on a CT scan, and you can see the areas on the CT that are normal. And if those areas get blocked up with mucus, in a few years, they'll be wide and they'll be damaged. And that's what we call bronchiectasis. So I mentioned those 3 times a week tablets, the anti-inflammatory tablets called azithromycin. That has been shown to slow down the progression of the disease. This is why the guidelines now suggest that we should take these. This is a study that was done in the Netherlands where they gave people these tablets or they gave people a placebo, and they did CAT scans at the beginning and the end. And what they showed was that the amount of mucus went down, so down is good. The mucus went down markedly in the azithromycin group, so those airways weren't blocked up anymore. And that meant that although in the placebo group the bronchiectasis got worse over time, it didn't get worse in the azithromycin group. It stopped the condition from getting worse. And you can see an example here of a patient who has lots of the white stuff at the bottom here is inflammation and mucus blocking the airway tubes. And that's the same patient's scan after the 3 times a week tablets. And look, you don't need to be a radiologist to recognize that there's much less of that white stuff. That's less inflammation in the lungs. This is the effect of taking an effective treatment early on in the course of the disease. So this is a really important message, I think, that we can do things to help patients early on in the condition. And that's why the ERS guidelines now recommend to use these treatments much earlier than they did before. We need to do better for you as patients, and our promise is with these guidelines that we're now going to do these things much earlier. So let's go back to the dream scenario, though. The dream scenario for me would be immediately after she starts coughing, persistent cough and phlegm, you know that she's likely to have bronchiectasis. We've raised awareness enough of bronchiectasis that the first person to see this patient says, that's probably bronchiectasis. She gets a CT, she gets straight onto those anti-inflammatory treatments or a new anti-inflammatory treatment, and the lung function never goes down. The disease is stopped in its tracks right at the beginning when she first presented. That's the dream scenario. And that's where our research is going to, trying to get the right treatment to the right patient early on to stop these sorts of things from happening. So in this dream scenario, 5 years later, she's still got 100% of her lung function, a great quality of life, and she never develops that Pseudomonas infection in the first place because she never gets enough lung damage for that to happen. So how do we get there with new treatments? Well, a lot of you have been asking questions in the chat about this anti-inflammatory treatment called brensocatib. That's the one that's now been approved in Europe and the US for bronchiectasis, and now being prescribed to patients in the US. It's an anti-inflammatory. It affects those neutrophil cells that I showed you earlier that go into the blocked airway tubes. And it reduces the number of chest infections. This is the number of people having chest infections over a year. But importantly, it also seems to slow down the lung function getting worse over time. So at the 25 milligram dose, which is the one that's been approved in Europe and the UK, the placebo group goes down like this. It doesn't go down after the first 16 weeks in the brensocatib group. So it can actually stop the progression of the disease in its tracks. And I mentioned the vital capacity earlier because that's a really good measure of the airway tubes being plugged. And this is this data here showing that the people who didn't get the anti-inflammatory, it went down by over 80 milliliters, which is a relatively large amount over a year. But it's almost completely flat for the 25 milligram dose. The difference there was 75 milliliters. Now, this is my bit where I say we really need to be better at explaining to people how important bronchiectasis is. Because when this data was shown to the regulatory authorities that are deciding on whether to approve medicines, they said, we're not sure how important stopping this decline in lung function is. But at the same time, a drug went up for pulmonary fibrosis that reduced the rate of decline in lung function by the same amount. And there was no doubt at all that people thought that was important. So we've always had this PR problem with bronchiectasis, that people don't take it as seriously as other conditions. And that fed through into some of these discussions about these new drugs. So one of the other things I want to try and energize us all about is make sure we keep explaining to people why keeping people with bronchiectasis healthy is so important. Why should bronchiectasis not be equally as important as every other condition? So these treatments can slow down the progression of the disease, in my opinion. to emphasize that, the previous one I showed you is lung function. I told you lung function and CT is the way that we monitor whether things are changing over time. And the earliest sign of things getting worse are those airways being plugged with mucus. Well, in this study with the new drug, Bronchiectasis, we did CT scans at the beginning and then after a year and measured the amount of mucus in the airway tubes. And that's another scan showing the mucus in the airway tubes. And this is a graph showing that whereas mucus got worse in the placebo group over time, because the disease gets slowly worse over time in some people, it went down markedly in people who took the 25 milligram dose of the medicine. And that's in damaged areas of lung. In healthier areas of lung, which is really important to preserve those and keep them healthy, it also went down markedly with this medication. So this is more evidence that early treatment with an anti-inflammatory drug can potentially stop the disease in its tracks and stop the mucus from blocking up the airway tubes. So having shown you all that data, you'll be saying, why can I not yet take this? The process of getting medications approved has now been gone through. It's now about getting countries to say that they're able to pay for this. And unfortunately, it's available in the United States, but not currently available in any other country. And that's related to problems around the reimbursement, as in getting an expensive medicine through the approval system in various countries. We'll see how that develops over the next year or two. But there is good news that medications that work in a very similar way, called Verducatab and Florenzacatab, are entering clinical trials or are in the middle of clinical trials right now. And one way that you can access these medicines as a patient is many of these trials, not just with these, but with other anti-inflammatory treatments, actually, after you've done a year on a trial where you might get the medication or a placebo, have what's called an open label extension, where you just get access to the medicine after a year long term. So that is a really important message for patients, that you can get earlier access to potentially effective medicines if you're willing to take part in a clinical trial. That's not going to be right for everyone, but it is an option if people feel that they want to get early access to these medicines. But I continue to hope that we will get approval or access to Bronchiectasis as soon as possible. In the last couple of minutes, there's been a few questions in the chat about what's being done for people with later stage disease. And often people with later stage disease have this infection called Pseudomonas. It's the most common bacteria that we get in people with bronchiectasis. And at the moment, it means taking a lot of antibiotics. And so we need treatments that are alternatives to antibiotics. Last year, I talked about an antibody treatment. Antibodies are part of your body's natural immune system that bind and immobilize pathogens. Antibody drugs are used very effectively in diseases like asthma. And now we've developed an antibody with a drug company against Pseudomonas. So it doesn't work as an antibiotic, it works as an antibody. So it could mean treating Pseudomonas without needing to give the conventional antibiotics. So we did a trial of this, and I wasn't able to show the results last year because we didn't have the results at that time. So it's great to be able to share the results with you now. We tried 2 doses of the antibody against the placebo, and it's just a monthly injection, so no more twice daily nebulizers. It's just a monthly injection. It's a small study. We only gave it to 37 patients in the UK and Spain, but it was to prove whether this was a good idea or not. And I want to just briefly mention that all of the conduct and design of the trial was actually done in partnership with patients. The ELF Patient Advisory Group designed how often we were going to do the dosing, how often to do questionnaires, how often we would see patients in the trial. And it was a really wonderful example with Alan, Joyce and Barbara of co-developing research with patients. But you want to know whether it worked or not. And it did. So it reduced the amount of Pseudomonas in the lungs measured in sputum samples by about 94%. So we would say 1 log unit, particularly at the 500 milligram dose. But the most important thing is how it made people feel. So there was a marked improvement in quality of life, a 12-point reduction in the symptom questionnaires, and we usually take a 4-point to mean a really big change. So one of the patients described this as life-changing, and there was up to an 80% reduction in exacerbations. Again, it's a small study, but really encouraging. And unlike antibiotics, there was no evidence that this was inducing resistance. So help is on the way also for Pseudomonas infections, and this is now entering a much larger trial over 400 patients that's going on right now. So my last slide is to say, because I've done inflammation, I've done infection, mucociliary clearance. A question I got from the PAG is, why can't people with bronchiectasis take modulators like the CF patients? Well, CF patients have a particular mutation that those medications target, but we're gradually learning that it's not so much non-CF and CF, but it's a bit of a spectrum, because some people with non-CF bronchiectasis, in inverted commas, do have, for example, one gene that's faulty. And so there are now some studies going on, and this is some encouraging results on the right-hand side with improvements in lung function and reduces in exacerbation with trying those modulator drugs in people with non-CF bronchiectasis. We need proper trials. We don't know yet whether they work, but it does show that it's more of a spectrum, and those communities are coming together a little bit. So I think it has been a year of extraordinary progress in bronchiectasis. Now's the time to kick on and make sure that we get the best out of this research and make a real difference for people with bronchiectasis. The dream I have is that we get earlier diagnosis. Now that we have treatments that work, rather than waiting and giving them only to the sickest patients, we predict and prevent, meaning we treat people earlier so that we prevent disease progression with disease-modifying treatments. We'll have several treatments, I hope, in the coming years. So it's about finding the right treatment for the right patient, and ultimately meaning much, much better outcomes for all of our patients. And the tools are there, and the research is there. We are so much further ahead now than we were when we first talked about this at the first patient conference. So that's the end of my talk. I have one final message, which is just a huge thank you to everybody that's been involved, both today and also in the research. So a huge thank you to the patient advisory group who've been involved in so many of those studies, all of the patients that have participated in the trials, and my EMBARC colleagues. And if you'll indulge me for a moment, also just a huge thank you to Jennifer Pollock, who spoke before me, who's been the EMBARC patient advisory group person for the last couple of years, but actually has been working with the EMBARC team for 7 years and is now moving on to pastures new. So a huge thank you for everything that she's done and all of the incredible research that she's done. And last but certainly not least, Jeanette Boyd, who's been heavily involved in organising all of our patient conferences, has actually been with ELF for 11 years and was with us the first time we ever involved patients in the first guideline back in 2015. It's amazing to think she's been with us the whole way, and has been an extraordinary help and an extraordinary advocate for patients. So we can't thank Jeanette enough for everything that she's done, and we'll miss her. I'm hoping she's moving on to the NHR. She's looked at bronchiectasis and said she's done so well there that it's sort of job done, and she needs a bigger challenge somewhere else. But I hope she really feels proud of everything that she's done. And thank you all very much for listening.
Brilliant. James, thank you so much. Well done for a beautiful talk. And as you said, the story ended really positive. There's a lot to be grateful for. There's lots of things going on. And I think also, the thanks that you gave there, that such a lot of this project is through patient power, advice, and I guess passion. So thank you to everybody for joining today. I think we've got time for questions. Suzanne, I don't know if you wanted to start.
There is there's one question that I think kind of covers a lot of some concerns that people have, and that's from a patient perspective. How do you push your own agenda forward? If, for example, you don't even have a specialist, or you have a specialist but they're not in the right area, or you might even have the right specialist but they don't seem to be following the treatment guidelines. I think it's great hearing all these things of how things should be, but I see lots of concern from people about, but that's not happening for me. Or maybe I can't take some of the treatments that are in the guidelines. So, you know, when you're an outlier, how do you advocate for yourself? How do you talk to your clinician without upsetting or annoying them?
I mean, maybe I can come in first. I hope a clinician would never be annoyed about a patient asking for help, because that's kind of why we're here, right? So that should not happen, and I hope it doesn't. Has anybody talked yet today about the patient passport or the patient checklist on the ELF website?
I'm just putting it in the chat.
Please do. Because we created this specifically for this problem. So our guidelines say all the things that I've just said about earlier treatment and giving people the right tests and the right sputum samples and the right treatments at the right time. But we know doctors don't read every guideline because they have to manage lots of different conditions. So I would recommend downloading this and taking it to your doctor and saying, am I getting all of these things? Because that helps them. Okay, it's got a link to the guideline. It tells them exactly what should be happening for a patient with bronchiectasis. And there might be very good reasons why some of them don't apply to you, because every patient is different. But at least then it can stimulate a conversation about what you need and why something might be suitable for you and something might not.
And I think that's
James,
great
yeah,
advice.
I'd just echo that point as well, is that when I've been at conferences, there are people that see patients with bronchiectasis that only do a bronchiectasis clinic, and there are people that do it in the middle of an asthma and COPD clinic. And when you're spinning lots of plates in a busy clinic, we will forget things. How many of you as patients have turned up wanting to ask us 3 questions and we've taken you off on the first 2 and you forget the 3rd question? So, you know, it happens on both sides of the fence, but that checklist is really helpful. And if I remember right, the checklist has actually been updated, because it used to say 3 infections, it's now 2, so that you know, it's very live document. And you know, asking it. I also find that when I do a letter to a primary care doctor and say this person should get 14 days of antibiotics, it's not as powerful. I actually tell my patients to take a photo of, in the UK we have the Asthma Lung UK leaflet, and I get the patient to actually pull out on their phone, can you tell me why you're not doing this? It's got a picture of it, because you never have the letter in front of you. So actually that GP never has time to go back to look in the letters. We all think they sit there listening to us like we're gods, and actually all they look at the letters these days are what antibiotics have been changed. So having that information, they think, can you just tell me why you're not doing this? It's quite an interesting open question. So I absolutely do challenge us, because we're human and we do fail. So I think that's really important.
And maybe I could just add a thought. Like I really agree, and no physician, no professional should treat someone else with questions like that. But if something like that happens, and if you get what is this checklist, and I don't have time for this, or something like that, I think it's important to for patients to get together. I think there's a lot of power coming from that.
Yeah. I think the other thing I would say is there are a lot of bronchiectasis patients being managed by non-specialists. It's absolutely fine to ask, if you're managed by a non-specialist, is there a specialist clinic that I could go to nearby? Because I do think bronchiectasis is a complicated condition, and increasingly I think it should be managed by people who are experienced in managing it. And we know from the EMBARC data set that more than half of patients are managed by non-specialists, so doctors that do everything, which is, they do their best, but there are definitely, if you've got difficult problems, you need to see somebody who's experienced in dealing with difficult problems. So don't be afraid to ask questions. It's it should be what doctors are there for.
Thank you.
Yeah, in terms of the questions, like maybe to you talk, but James, that somebody's asked a question about lung function, and can we make lung function better in bronchiectasis as new drugs come through, is probably a little bit of a tweak of the question, but would you care to comment on your thoughts on that?
Yeah, absolutely. So I think lung function tests are really important to monitor how the disease is progressing, particularly if you're having a lot of chest infections. It can go down because there's damage to the lung, but it can also go down temporarily when the lungs are full of mucus. So if you clear out the mucus, the lung function tests can get better. There's also other, like inhaler treatments, bronchodilators, we call them, that can improve some aspects of the lung function. And so I think it's important both to get the lung test, but also to ask your doctor, what does the lung test mean? And if the lung test gives you a percentage that's lower than 80%, which means that you've got abnormal lung function, ask the question, are there things that I could do to improve my lung function? Because there often are.
Brilliant, thank you.
I noticed there's a few questions more recently actually around trying to support appetite and weight gain and diet. And I don't know whether this is related or not, but there's also been a little discussion around probiotics. So can I throw all that into the mix? And I'd love to hear your responses to that for the chat.
Yeah, so being underweight is a common problem for some people with bronchiectasis. It's particularly common, I find, I don't know your experience, Tony, but in people who've got certain things like NTM, a lot of my patients can be quite underweight. There, a dietitian can be very helpful. Calorie supplements can be very helpful because it's sometimes, particularly if you don't have much of an appetite, it can be hard to force yourself to eat enough calories to put on weight. There are also some medications that can help with boosting appetite, particularly if people have associated anxiety and depression. There's a medication called mirtazapine that I use quite often that boosts appetite, not for everybody, but for certain patients. And so again, there's quite a lot that we can do in terms of just boosting calories to help with being underweight. It is a good thing to do because your body is essentially fighting all the time with this mucus and the inflammation. So it needs fuel to fight the bugs and to control the inflammation. If it doesn't have enough fuel, if you've got a calorie deficit, we know that patients do less well. So don't neglect diet and taking in enough calories.
Yeah, just to add in on that, I think I typed in one of the earlier chats, is that certainly if you're struggling, if you're breathing fast, you're unfortunately having to swallow lots of mucus, your stomach feels full quicker. So quite a lot of dietitian advice that I've heard over the years is to pivot and stop thinking of 3 meals a day and think of 5 mini meals a day. And they often say when you're off your food for whatever reason, either it's antibiotic side effect or just you're feeling poorly, is you probably need to think slightly differently about the calorie content. So, 5 fruit and veg a day is great, but if you're not getting any calories in, you're probably needing protein and fat to fight off the infection, which are higher calorie foods. So, do think about changing what you do temporarily. So I think that's important.
Yeah. So for the record, Tony just said you can have chocolates and cakes, guys.
Because that's what I do when I'm not well.
But if you don't look thin and fabulous in your bikinis on your holiday, that's not my fault. Okay, that's the scale. James, there was a few questions about azithromycin, and you were advocating that we should have it. And somebody actually said in one of the questions, if I'm all these drugs, I'm on azithromycin. And my reply to them was, if you were on all these other drugs and you were still having 2 flare-ups, I think you should be having that conversation about azithromycin. Would you? That's very much where the current guidelines are saying that if you've got ongoing symptoms and exacerbations of 2 a year, you should be turning the dial up. Is that a fair comment?
Yeah, so azithromycin is a really effective medicine, and because it's an antibiotic, people are a bit nervous about giving it, but it's given at a very low dose, below the dose at which it would be given as an antibiotic to fight inflammation. And it's really effective. It reduces symptoms and it reduces chest infections. And as I showed you with the data, it stops the disease from progressing as much as it would otherwise. So the guidelines have changed to say if you've got 2 flare-ups, you should certainly be on it. If you've also got terrible symptoms, even if you haven't had 2 flare-ups, you should think about being on it. There are some people who can't take it. There's side effects, and there's some types of bronchiectasis like NTM where we need to reserve it because it's used as a treatment for that. So it's not for everybody, but it should be used a lot more than it is at the moment. It's currently used by about 1 in 10 people, whereas we know about 50-60% of people have chest infections regularly, and so it should be used more than it is at the moment, which is also a message that Jen pointed out. Lots of people with high burden of disease and chest infections, but not really getting any treatment for it apart from airway clearance.
I mean, that's a really important point I'd just like to stress is if you're going to see your clinician and your lung function test is steady and you've had 2 flare-ups, I think increasingly we are seeing as experts is that damage is still going on there. It just hadn't shown up. FEV1's quite a good test, but it's not perfect. So, you know, can you get that turned down further? And our experience with macrolides are it's actually a drug that's relatively hard to get people off because they feel much better on them, which tells you something. So don't be frightened to ask if that helps. One of the questions. Here's the thought grenade coming in. So James, what's your practice when somebody's on long-term azithromycin and then they have a flare-up, which will happen? It will happen. It just reduces the number over a year. Do you ask them to stop or not? Because that's an old chestnut that often comes up, and I thought it would be a good place to discuss it.
So this comes up with my patients all the time. So I don't ask people to stop. And I'll explain why. There's an old study that shows that you can find azithromycin in the lungs about 100 days after your last dose of it if you stop it, because it gets concentrated in the cells in the lungs trying to reduce the inflammation. So stopping it for 7 days or 14 days while you're taking another antibiotic, it's probably pointless because the azithromycin's still in there, and it complicates things because sometimes people don't restart them or they aren't sure what they're meant to do. The only exception is a medication called ciprofloxacin, because the two of them can kind of fight each other and cause a change on the heart tracing. So we say stop it for that one, but your doctor should tell you to do that.
Brilliant. I've been terrible at during the session because we're 2 minutes over, but I do want to ask one last question. I think it's super important. It's to Eliza and Jen. Absolutely fantastic stuff. Every time we get patient feedback, we learn something. How can patients feed into the next survey about questions? So I always ask patients about bladder leak, for example, and that's a multimorbidity thing we don't talk about. How can patients in the future say, I think this would be a really good topic to ask, in the survey? How do we get that in?
Elisa, do you want to take this or will I? I don't mind.
I'm not sure how to answer, but maybe like from patient groups, like for example, this survey was drafted exactly as we said before by Embark and the patient advisory group from OFELF. So also, I mean, even people that are representatives in their own countries, they can speak to us, and we are open, and we need more surveys, more research. Yeah.
So that's a brilliant. I thought that's what you'd say. So that means if your favorite topic wasn't in, it's because you haven't got involved enough to ask the question. So please think of it for next time and feed into the process. So I think at this point, I'd like to thank Suzanne.
Sorry, Tony, I'm just going to say there's also the new hub that's coming, of course, and there'll be lots of
course, yeah, absolutely. Sorry for the slide.
On there as well.
So I think, Suzanne, I pass you over to Stefano to thank everybody for this session, but for the whole of the day and to round up. Thank you.
Well, I will start, Suzanne, and then I will give you the final words. I think that this has been just a great day. Now it's almost 4 p.m. In Italy, and we started this meeting 6 hours ago. But it was really enjoyable. I've learned a lot, and I'm really proud of being part of this community. At the end, we had almost, I think, 20 speakers in this meeting, including clinicians, researchers, patient representatives, We had almost 15 or 16 presentations, 2 panel discussions, and we cover very important topics in the management of this disease, from the fundamentals and patient journey early this morning, diagnosis, care pathways, patient experience. We talk about infection. We talk about sputum, Pseudomonas, NTM, fungi. We had a session on living with bronchiectasis, discussing about travel, environmental issues, anxiety, quality of life. And with the last speakers and Professor Chalmers, we mentioned new therapies, research progresses. So I've been really I'm enthusiastic of what actually we have done. If I can share my screen, I have prepared just one final slide, Suzanne, and then I will give you the stage. Let me see if, yeah. Can you see my slide?
Yeah.
Okay, so there've been almost I think 300 questions in during this meeting, and these were the most common keywords that people put in the Q&A questions, including infection, Pseudomonas, sputum, the management of the disease with antibiotics. We answer question about physiotherapy, airway clearance, a lot of question about brensocatib. Professor Chalmers mentioned this a few minutes ago. There were a lot of questions also on gastroesophageal reflux disease, chronic rhinosinusitis, comorbidities. We also address this important association between bronchiectasis and other systemic disease. So I think at the end of the story, between presentation, talks, and answers, we touch the most important points in the management of this disease. So I'm really proud and happy to have shared this with Suzanne. And Suzanne, do you want to do a resume also?
Sure. Yeah. No. This is the third conference that I've attended. It's the first one that I've actually been involved with organising, presenting. So it's been a huge honour, and I've learned a huge amount as well. Just when you think you're kind of getting to grips with the subject, I'm pleased to say that things are moving on. And it's great to see so many advancements in this area and just general increase in knowledge. So thank you so much to all professionals and patients for sharing that. I do have one final poll actually for the day. So Claire, if you would mind putting that poll up, that would be great. You can actually just click straight on the screen on the numbers. You don't need to put it in the chat. So we'd just like to know now how you would rate your knowledge of bronchiectasis following today's sessions. So if you could just stay a couple of minutes to click one of those numbers, that would be really helpful for us in monitoring how we've done today. Just click straight on the screen. You don't need to put it in the chat or anything. You can just click that page. And hopefully the answers will come up shortly. I can see lots of numbers. I can see people putting numbers in the chat that are higher than the scale. So we've got 19, which is excellent. So that's great. From the results, though, we can see that I think the highest figure before, the most common, was around 7, and now people are up at 9. So that's a fantastic result to be able to shift people's understanding over the course of just a few hours. Stefano, did you want to, or have you, I think you may have concluded, you've done many thank yous. Did you have anything else to say?
No, just to thank all the speakers, the patient contributors, all the session chairs, of course the Embark Steering Committee, our bronchiectasis patient advisory group, And I would like to thank you all for joining us. We now are more than 300 participants, so this is such a great success. If you want more information about bronchiectasis, then you can visit the European Lung Foundation Information Hub at www.europeanlung.org. And there you will find a lot of information, resources, and you can also take a look at the latest information pages on NTM, non-tuberculous mycobacteria. This is the website, and our guide to sputum, and this is the other website. Suzanne?
Thank you. Yeah, so please stay in touch with us, sign up for the ELF newsletter, and if you're a clinician interested in finding out more about Embark, the links are on the slide here. So thank you very much for staying with us, those of you who made it to the end, and to everybody involved. And thank you.
Thank you.